like to apologize obviously for the late start, but we are going to get moving quite shortly. There's still some people waiting in the reception area and on the floor lower behind us. So if you could just please move forward just a little bit to allow people who are still coming in to be able to get a seat, then that would be much appreciated. But yes, thank you so much for coming today. It's a wonderful event. I'm so privileged to have been invited to come back this year. The wonderful people at the Caribbean and African Health Network have given me that privilege, and I'd like to kick us off very quickly. But before I do, I'd like to introduce myself. My name is Nick Katuna. I am a workforce correspondent at the Health Service Journal, and joining me is Melissa Segudo, who is also a journalist who's been featured in various publications like The Guardian and so on. So we will be taking turns in making sure that this event runs as smoothly as possible and to give you the event that you deserve. So before I get into the main event, I'd just like to go through some quick housekeeping rules. Number one, we do have photographers on site, so if you do not wish to be photographed, just let one of the volunteers know or someone close. There are no planned fire alarms, so if you do hear a fire alarm, please make sure that you get to the nearest exit as promptly as possible. Please put your phones on silent, just to make sure that we're able to hear the speakers and everyone is able to enjoy them as they should be. And the toilets just around the corner from here and on the lower floor, so if you do need to pop out, then that's totally fine. So we're going to start off with a, sorry? We're going to, sorry? We're starting at 10 o'clock, so if you just give a few more minutes, then we will be able to kick off today's session. I'm going to now hand over to Melissa to transition to the next part.
Everyone. My name is Melissa Segudo. I'm just coming up here to basically repeat what Nick said. If everyone can make their way to the main auditorium, which is Mountbatten, that is on the 6th floor. If you can all make your way upstairs now, because we will be starting very shortly. Get yourself some refreshments, get yourself some orange juice, and we will be starting quite soon. So please make your way to the main auditorium on the 6th floor, which is Mountbatten. Okay, so I'll be back again. Me and Nick will be taking you through this amazing event that we have today. And yeah, get refreshed and buckle up. Just to let you all know, everyone, the first speakers will basically be starting at 10 o'clock, so that is in 3 minutes. Apologies for people who are still downstairs trying to get their passes, but hopefully that will move along as quickly as possible so that we can get started at 10 a.m. So please make your way up to the main auditorium. I hope that you can hear me in other rooms and other floors as well. So yeah, everybody make your way to the main auditorium, which is Mountbatten on the 6th floor, and we start at 10 a.m. starting the summit shortly. So everyone, please make your way to the main auditorium, and we will be beginning at 10 a.m. It's currently 10 a.m. now, so we don't want to delay this any further. If everyone can please make their way to the main auditorium on the 6th floor, which is Mountbatten. starting right now. Thank you so much for joining us this morning. Apologies for the delay. That was not planned, obviously. I appreciate everyone might be trying to get some refreshments after the wait, but we are ready to start now. We have a fantastic event ahead for you today, so please take your seats immediately. I know some people saw me outside trying to wrangle everybody in, but we do want to start now so that we have no further delays. Thank you. So Nick, my co-host, well, first of all, my name is Melissa Segundo, and I will be hosting this event today along with Nick Catuno. He is a fellow journalist like myself. I formerly worked at the Daily Mirror, and now I'm doing freelance, but I am also the host of the YouTube series The Space, as well as the founder of the weekly newsletter The Source. So I'm really pleased to be here today to welcome you all to this amazing event that we have, where we're going to talk about health inequality, which is so important. So I'd like to welcome you all to the Health Inequality Summit 2025. It's going to be a fantastic event. So let's give yourselves a round of applause, please. So we are pretty much going to get right into it. Our first speakers will be LDNinspire co-chairs Juliet Amoa and Sedi Frederick. So Juliet is an Associate Director in Equality, Diversity and Inclusion for Community Health and Engagement in the Borough of Lambeth. And Sedi is the Independent Chair at the London Legacy and Health Equity Partnership Oversight Group. So they will come on right now, and I have the pleasure of introducing them. So round of applause for Juliet and Sedi.
So, a massive welcome to you all, and I'm so sorry that we're running so late. We will try and catch up on time. So welcome to the second Black Healthcare Summit. I can't believe that we're here again and we've got this far, so it's really exciting that we have. My name's Juliet Amoa, as Melissa said, and I co-chair the Inspire programme with the wonderful Sedi Frederick, who will talk to you very soon. I'm sure lots of you know Sedi. We co-chair the Inspire steering group, and it's made up of members from across London that are key stakeholders who have massive impact and influence across the whole system. They are a great group. Lots of them are here today, so you'll get to meet many members and connect with them. We are supported by Khan, our wonderful delivery partner, who have been driving Inspire forward in London for the last 2 years. We thank them for all their support, and they've been amazing in organising us here today. I've been involved with Inspire with colleagues across London since 2021, when Lambeth Inspire started, and then LDNinspire was the legacy. And it was co-designed with community members, which was amazing. We're so passionate about addressing health inequalities for the Black community. We're committed to ensuring that we really amplify the voice of our community to create whole system change. We continue to address these inequalities through partnership working, collaboration and engagement, and that is the main kind of method for us to really start to address some of those whole system issues. The impact of the current financial climate, I think we're really aware of, and how that could really impact those outcomes and inequalities for our Black communities. So we really need to make sure that we're taking action. We recently had a really good away day with our steering group, where we decided to look at how we could give Inspire longevity. And so rather than calling it a programme, we've decided to call it a movement. And I think that should really help make sure that people feel committed to it and involved with it. So our new mission statement, we have it here somewhere, but the mission statement is, LDNinspire is a movement dedicated to empowering Black Londoners to take control of their health and well-being. Through leading community engagement, collective action and driving system change, we strive to reduce health inequalities across Greater London. So we hope today that you connect, engage share learning, and it's a safe space for you to really engage in what we can do and take action. Because at the end of the day, we will have calls to action as to what we will be doing next to change those health inequalities. I'm now going to hand you over to Sedi, my wonderful co-chair.
Good morning, ladies and gentlemen. As Juliet has said, apologies for running late. I had prepared a rather short introduction today, so I'm going to have to try and condense it still further. But as has been said, can I add my thanks to those expressed by Juliet to you all for joining us here for our second Black Health and Equality Summit. The fact that there are many hundreds of us here today speaks powerfully to our collective belief that we need to do more to address the health inequalities faced by many of our community here in London. Can I also thank the team from Cairn and the Inspire steering group who have worked so hard to organise what I know will be a great summit today and have worked very hard during the year to deliver the Inspire mission and agenda. Can I also thank the organisations who have provided financial support to Inspire over the year? Not as much as we would have liked, of course, and their support will continue into 2025 and beyond. Finally, can I also thank the sponsors of today's summit, without whose support we could not have made today happen. Whilst we're looking again at the health inequalities faced by Black African or Black Caribbean communities from a London perspective, today's summit is of national importance. There is a well-worn saying that the more things change, the more they stay the same. And certainly over the last 12 months since our last summit, there's been a lot of change. New government, new challenges. I had a list of those challenges, I had a list of the things that this government have been doing, but time is against me. But what I will say is, despite all that change, the health inequalities faced by our communities have largely stayed the same. What I do, however, want to acknowledge is the work undertaken by the London Mayor's Office to improve air quality in London with the expansion of the ultra-low emission zone, because that has improved the health of all Londoners, but as we know, the disproportionate benefit has been greater and greatly felt by those communities that we're here to serve. Juliet has talked about Inspire's journey from a project to a programme to now a movement. And fundamental to this change is Inspire supporting and enabling local communities, their leaders, and those with lived experience to find their voice, to question, challenge, demand improvement, and to ensure that they get the answers that they need to take control of their own health. Inspire believes that knowledge is power, and we want more power to be held by those with the greatest stake in the system. Today you will hear from some brilliant speakers and join thought-provoking workshops. Please get as much as you can from the day. Don't be a spectator. Keep asking yourself, what more can I do and what more can my organisation do to reduce health inequalities faced by Black communities in London? Then commit to doing it. Thank you very much indeed.
Thank you, Sally and Juliet. Just to make a quick note, we do have an overflow room, so if you are standing at the back or need to find somewhere to sit, you can go to the back and someone will direct you to the overflow room where you can still see the event. So moving on, we are going to introduce our first guest. It's my great honour to welcome our next speaker, Paulette Hamilton, who is an MP and chair of the All-Party Parliamentary Group on Black Health. Before entering Parliament, Paulette dedicated over 25 years to the National Health Service as a nurse, where she witnessed firsthand the inequalities that continue to affect Black communities across the United Kingdom. This professional experience, combined with her deep community connections, has given her unique insights into the challenges we've gathered to address today. Since being elected to Parliament, Paulette has been a tireless advocate to health equity, working across party lines to build consensus and drive meaningful policy change. Under her leadership, the APPG on Black Health has become a vital forum for addressing systemic barriers that continue to contribute to disparate health outcomes. Today, she'll be sharing her perspective on health equity, legislating for improved outcomes, a critical topic that sits at the intersection of policy, healthcare delivery, and social justice. So please join me in giving a warm welcome to Paulette.
Right, good morning, everybody. Good morning, everybody. Fantastic. I know we've started late, and I know people in the room already, you're fed up of hearing people talk, but bear with me. I'll be one of those, okay? Right. So I've already said good morning, everybody. I'd like to begin by extending a special thanks to the Caribbean and African Health Network, especially Charles and Professor Faye and the team for delivering this summit on behalf of LDNinspire. Your dedication and hard work have made this event possible, and I'm truly honoured to be among so many passionate individuals committed to tackling Black health inequalities in our community. Isn't it wonderful to see our community and others come together to make a difference? It is vital that we do come together to ensure that these conversations continue to take place and continue to be heard in the places where they're so important. This is the second annual summit, and I am told that last year's event was such a huge success that we needed a bigger venue today. That speaks volumes about the growing momentum behind this movement and the urgency of our mission. Throughout the day, you will hear powerful testimonies outlining the scale of health inequalities facing Black communities in this country. We know the statistics. We know the devastating impact these disparities have on Black communities. We also know Black people have a life expectancy nearly 5 years shorter than white people. We know that Black infants face more than double the infant mortality rate of white infants. We know that Black women are nearly 4 times more likely to die in childbirth than white women. We also know that these issues are not new. These are not just numbers, they represent lives, people you know, lives that have been cut short, families that have been shattered, and communities burdened by systemic inequalities that have continued for far too long. But I'm not here to repeat what we already know. Instead, I want to talk about solutions, particularly community-led solutions that drive real, lasting change. And more importantly, this is how we ensure that Black health inequalities are not just discussed, but tackled head-on. Before entering Parliament, as was said in the introduction, I was a nurse. I was very proud of being a nurse. I have seen at first hand the injustices spot on, but as a nurse, sometimes when you're doing, it's very difficult. How do you make change? People, numbers, people driving change through their communities is how change happens. Patients dismissed, symptoms overlooked. I've seen it in my own family with my daughter who nearly lost her life and her baby because nobody would listen to what she was saying. And diagnoses, if I get that right, that were misdiagnosed or left untreated. Complacency is no longer an option. The government strategy does allow for prioritisation of health equity, but prioritisation demands action. Don't tell me you're going to prioritise my needs when nothing comes behind it. So it cannot just be words. It means ensuring that every policy, every funding decision, every healthcare reform takes health inequalities into account, investing in Black-led organisations that understand our community, that listen, that also that they're at the grassroots, and they're also at the decision-making processes. Because one of the most effective ways to close these gaps is through community-led approaches. A community that works together gets results together. Black communities know their own needs best. We must empower Black-led organisations, healthcare professionals and grassroots groups who are already doing the work, providing culturally competent services, advocating for better healthcare access and educating our community. If we are serious about tackling health disparities, these voices must not just be heard, they must help to shape policy. By turning today's discussions into tangible actions, we can ensure that Black health moves from treatment to prevention and from hospitals to communities, which is part of the Labour mission. The truth is, we must remain vigilant. We cannot afford for Black health to be pushed aside in the wider NHS reform. We must be proactive and hold decision makers to account to ensure that Black communities do not bear the brunt of funding policy failures. That means keeping up with the news, lobbying our MPs and contributing to the movement. These are the tools you have for demanding change and ensuring that Black health remains at the top of the political agenda. This is where the Black Health APPG plays a crucial role. When I became an MP, I vowed to make health inequalities a cornerstone of my work. In February, I had the honour of chairing the all-party parliamentary group, or the APPG on Black health. The group aims to raise political awareness of the stark health inequalities disproportionately impacting Black people in the UK, hold decision makers to account, and to ensure Black health remains a priority in NHS reforms. The APPG creates a forum for parliamentarians to listen, learn, and act to ensure that the issues we discuss today are heard. The Black Health APPG was formed because there was no dedicated space in Parliament to bring together policymakers, healthcare professionals, and community leaders to address the full range of Black health disparities. As the chair of the APPG, this work is actually personal to me, and if you look at me, you know why. When the Khan team came to me with this year's priority areas for the APPG, I was delighted that the first area of priority was fibroids. Having personally battled with fibroids, along with other women in my family, knowing how debilitating it is. I understand the physical and emotional toll they can take. Sorry, I'm going to miss that bit out. It was a challenge. It was a challenging experience that opened my eyes to the widespread impact of this condition on black women. And I actually asked a question to the Minister in Parliament yesterday about fibroids regarding the research that has not been done in this area when so many women are living with fibroids. Yet despite 90% of black women developing fibroids by the age of 50, research and treatment remains shamefully underfunded. This injustice runs deeper. Black women don't just suffer more fibroids, we suffer them earlier and experience more severe symptoms. We're driving change through targeted work streams to challenge these disparities head on. Right now, we are developing an integrated black health framework, a practical tool to help the NHS and integrated care boards address health inequality in a more structured and systemic way. Please remember, at the moment, we are losing NHSE, and also we have 50% cuts in our ICBs. So we must make sure we keep up with what is going on so that we're actually ensuring we're channeling things into the right places. We are fighting at every level to ensure that black people are included in medical research and clinical trials so that treatments are developed with our communities in mind, but we cannot do this alone. This movement needs you. It needs all of us. The APPG is as strong as the voices within it, and my God, the voices within it are strong. And that is where all of you come in. If you're a health professional, advocate for better training and culturally competent care, if you're a community leader, partner with us to bring grassroots voices to Parliament. And for everyone here, contact your MP and urge them to join the Black Health APPG. As we look ahead, our path is clear. We will continue engaging with government ministers, NHS leaders and public health bodies to ensure that black health remains a priority. We will centre black voices in policy making because equity demands collective action. We must expand our reach, bringing more parliamentarians and stakeholders into this conversation. So before I finish, I want to say how inspiring it is to see so many of you here, because this work is not easy. It takes persistence, it takes courage, it takes unity. But together we can and will make a difference. We will not sit by any longer while these decisions are taken on our behalf, because health equity is a fight we must win. So let's leave here today not just motivated but mobilized. Let's work together and let's win, because when we win, our communities remain healthier for longer. Thank you very much.
Thank Thank you so much, Paulette. I mean, hearing her talk about women and maternal health, how many women do we have in the crowd right now? Everything is so real, so thank you so much for that, Paulette. And up next, we have a professor. We have Professor Nadi Hakim. Under his name, he has MD, PhD, Honorable D, Arts, and he is also here to talk to us about skills, not scars, and an international perspective. So if you want to give a round of, oh, here he is, for Nadi Hakim.
Ladies and gentlemen, Mr. Chairman, good morning. First, I'd like to thank Charles Kwaku, the CEO of CAN, for inviting me to be here today, and I'm so humbled and impressed by the crowd here today. I'm going to talk about what I call skills, not only scars, and I'll explain to you what I mean by that. First, I'd like to make a declaration of interest. You'll be surprised to know that I'm Nigerian myself. So, and obviously proud to be. So this is my declaration. So I'd like to talk about black health and kidney transplants. I've been a kidney transplant surgeon, other transplant surgery for the last 30 years. So obviously I've dealt with a lot of patients in the NHS. But in addition, I thought, as the president-elect of the Transplantation Society, to offer my skills and training, as Mrs. Hamilton mentioned, training is very important to people in Africa, on the African continent. So I will not be very long. I know I have only 10 minutes, but for the last 13 years, I've been traveling to Africa as a single surgeon, because obviously I go on my own and I offer my skills. And I've done over 350 live-related kidney transplants, and they're all kosher kidneys. All the transplants are done because the HLA is done in the UK and confirmed that the live-related is indeed the case. There's no cheating going on, so I insist on this because this is my job as the Transplantation Society president. And we follow what they call the Istanbul Declaration. You can look it up. So I've been to 3 West African countries so far. I started in Nigeria. I've done transplants in Abuja, Lagos, and Accra. And soon we'll be doing some in Liberia, Zambia, and all the way to St. Kitts, because obviously we deal with the Caribbean islands too. I was invited by the Prime Minister of St. Kitts to do the first kidney transplant there in not too long. We're just looking at the first donor recipient. I'm going to show you some pictures. That's, I think, the nicest way to present. This is in Abuja, where the nurses, doctors, and actually the gentleman in the middle is my own son, who goes with me. He's a transplant trainee, vascular trainee at St. Mary's Hospital, so he goes with me to help me with the transplants. Actually, as a matter of fact, I came back on Monday from Nigeria. I was there for 2 days, where I performed 7 kidney transplants in 2 days. Now, to give you an idea, 7 kidney transplants, meaning 14 operations, because I have to do the donor and the recipient. I can tell you in the NHS, it will take 3 months to do 7 kidney transplants, live-related, and I'm not exaggerating. So to do 7 successful kidney transplants and flying back on Monday morning is, I'm sure you agree, a big challenge. But I was, thank God, confident enough to leave the patients with the local surgeon, but I'm very comfortable that they will do well, and I keep in touch with the hospital by WhatsApp with the results. So this is one of the hospitals in Abuja. It's called the Caroline Medical Center, with the nurses, doctors, and when I transplant, all the surgeons in town will come and observe, and I take them through transplants too, so they learn. And this is what I mean by leaving skills and not just scars behind. So I don't know whether somebody can start the video. Yes, just to show you, this is a true video of there's no lift in the hospital. These are donors which were done the day before. And look at this, they are walking down the stairs to go to the room to give space to other patients. So look at them, they are walking as if nothing happened. These are 2 donors out of the many, many, many donors we've done. So to give you an example of how healthy they can be immediately post-op, instead of and offering their kidneys, which I always say is such a priceless organ to offer. So this again, if you can show the video, please.
You are the last patient we've done last night, and you're doing very well. Kidneys functioning nicely. Well done. All good? Happy? Well done. No problems, no complications, nothing.
So see, it's very quick walk round because I know they're doing well. I don't have to spend an hour with each patient, just one after the other. Otherwise, there's no time.
No problems, no, you have all good, happy?
African patients are the ideal patient, I can tell you. Perfect. They're always happy.
Yes, very well.
Always happy.
You must be happy.
Next, please. So this is actually a story, a patient who I've done many, 2-3 years earlier, and I bumped into him at the hospital. If you could run the video, please. He will tell you what he thinks about it, please.
I had a transplant, kidney transplant 7 months ago. The surgery was successful. And 7 months plus now. So seeing them, coming to them, I feel happy and delighted.
Fantastic.
Thank you very much.
You know, when I saw him today, I looked at him and I thought this guy must have had a successful kidney transplant. Because he looks so good, so healthy.
Remember to do your follow-up. You are doing very well. You are looking good. Professor Nadia Hakim, thank you very much.
This one, actually, this is a picture taken just this weekend. This lady comes to the hospital and says, "Oh, you don't recognize me." I said, "Sorry, no, I don't recognize you." She said, "You did my transplant 6 years ago." And she came with her husband, and as you can see, I mean, she's amazingly with a perfect kidney function. This is what is good about transplantation. You see, this is, you plant that seed, and 20, 30 years later, you see patients doing very well. Now we move to Accra. This is UGMC. I don't know, there must be some Ghanaians in the room. UGMC, 11 kidney transplants done last year in 2 visits, and again, did very well. This is the MDT before the transplant with all the team. You know, the gentleman, the second gentleman on the right here, or left to you, sadly, there's a very sad story. He was the chairman of the department. 2 months after all this, he developed, unfortunately, gastric cancer and died. So that was very sad. So you see here, I'm with Mary, who is the senior urologist, doing the transplant with her, showing her how to do it. Big theaters, UGMC is quite impressive. Actually, it's even better than any hospital I've seen in the UK. It's very, very good. 12 operating theaters, outstanding. And you see, this is the intensive care, everybody wearing gowns. You will never see this in London. I mean, it's unbelievable. Everybody, you're not allowed to breathe inside the ITU unless you have got the mask and the gowns. They are very, very, very impressive. This is actually going to Lagos. We're traveling all over the world. Lagos at the St. Nicholas Hospital. I'm sure you've heard of it. That's where they've done the first ever kidney transplant in Nigeria. And I go and help them with Dr. Ibun in the middle here, Bang Boy, you've probably heard of. And this is the last transplant, one of the last transplants done in Lagos. And you can see this is a huge ascites. I land in the morning and said, you're going to transplant this gentleman. I said, are you serious? He said, yeah. There were 25 liters of ascites inside that abdomen, so which I had to suck out and transplant this patient who was, in addition, HIV positive. So a lot of demanding tasks. So, ladies and gentlemen, I've got 30 seconds left, and I will be respecting my time. So thank you so much for your attention. Thank you.
Well, that was amazing to watch and very inspiring. We're going to now move on to our next speaker. It gives me distinct pleasure to welcome Professor Margaret Ikpo, who's the Vice Chair of Professional Development and Standards at the Royal College of General Practitioners. Professor Ikpo brings an exceptional expertise to our Black Health Inequality Summit as a leader in primary care education and an advocate for community centre healthcare. Her work has been instrumental in promoting inclusive training pathways and addressing systemic barriers that affect both healthcare professionals and the diverse communities that they serve. Today, she'll be addressing the value of community involvement and patient safety and exploring how meaningful community engagement can transform healthcare delivery and enhance patient safety, particularly to underserved population. So please join me in giving an extended warm welcome to Professor Margaret Ikpo.
Morning, everyone. Oh, come on, you did better for Paulette. Morning, everyone. Right, I'm a bit nervous. I don't know why. So forgive me, I've got to set up my little house here first. So I just want to say thank you for the privilege. Like Nick said, I was here last year. It was amazing. It was electrifying. And it's an absolute privilege. And I would like to thank Sedi and Juliet for inviting me back. I'm here because of Khan, if I'm honest with you. My journey started 5 years ago, but I'm conscious of time. They haven't started the timer yet, so that's good. But I'll explain things as I go along. So essentially, after I started doing some voluntary work with Khan, I thought, with regards to change, if nothing changes, nothing changes. So, and that's why I got involved with my Royal College, because we had very little representation. So part of my remit, I look after 3 things in the college: the exam that they need to become a GP, education, and our annual conference. And I have another hat with the National Institute for Health and Social Care Research. And I enjoy that a lot because that's about embedding research in primary care settings. Before I forget, if you do anything today, please visit some of the stands downstairs, have a look at the posters, particularly the ones around Black health matters. So prostate cancer, there's stuff on diabetes I wasn't aware. 1 in 7 of us maybe actually be underdiagnosed with diabetes. Black Health Legacy downstairs will tell you all about it. So moving on to the next slide. Do I have to do the next slide? Oh, there's a pointer. Next slide, please. Let's do the next slide. Those are my declarations. I have to declare those. And the next slide. So last year I did something slightly different. I realised I was speaking after 3 heavyweight speakers, so I linked my talk to more of a pictorial journey using R&B as a backdrop. I would like to start with my standard slide, because this is where it all started for me. 5 years, and we must never forget, going back to the last slide, we must never forget the sacrifices of our colleagues, loss of family and friends. In terms of patient safety, as a community, we've got to stay involved to ensure that all the people that we've lost have not died in vain. Next slide, please. So I don't know if Vanessa Appy is here. She said, you've got to do the presentation you did last year with the R&B slides. And I said, but it was so whack though. And she said, no, it was really good, you've got to do it again. I said, well, there's no part twos. I don't like doing part twos. And so I got into a big heated debate with my family yesterday about this. And my daughter said, look, just go for it. You know, you've got people who've never going to have seen this before. And my son looked at the slide and said, well, if you're putting Drake in there, you can't put Drake in there. So I'm really going to do this. And as Juliet says, I'm not going to hold back. So for me, trustworthiness, as 20 years I've spent as a GP, with absolute certainty I can say we can't understate the critical role of trust in a doctor or healthcare professional with a patient relationship. As a saying, we say as GPs, we look after our patients from cradle to grave, and trust forms the bedrock of that relationship. But it requires open communication and honesty. So my patients need to feel confident in what I say, credibility. They need to feel confident in what I say I will do. That's my reliability. And they need to entrust me with something. Sometimes some sensitive stuff, like I don't need to know what you did with that gadget you bought on Amazon yesterday. Seriously. And it needs to be about them and not about me. And those things increase our trustworthiness. Next slide, please. How have I got 6.5 minutes left? So when trust breaks down, we know what happens. Trust takes a long time for us to gain someone's trust, but you can lose it in an instant. And what it does, it empowers us to act with empathy, vigilance, and accountability. Those three things form the cornerstone of trust. I forgot to apologise to anyone born after 1999, because you might not get some of these slides, because my medical students looked at me blankly like, we don't know who half these people are, Margaret. Next slide, please. I'm hoping Habib Nakvi, who's talking later, who's the chief exec from the NHS Race Observatory, he will talk about their trust report, I'm sure of it, because when trust breaks down, it affects our relationships. So what can we do? I'm going to talk about what you can do from a patient perspective, what we can do as healthcare professionals, and what we can do as a collective. Next slide, please. Now, sorry, I can't stop Aaliyah dancing, so just have to ignore that. As patients, I know there are some healthcare professionals, when your patient comes into the office with a list, a paper, they will say, my heart's sunk. And I would encourage you to think, and some of you are laughing, this is true, you think, oh my God, I'm going to be here all day. But as a patient, write stuff down, because when you're in the moment, you might forget. And if you know there's a lot on that piece of paper, ask for a double appointment. No one can tell you that you can't have a double appointment. It's important that you know your rights. And if you're not happy with what someone has told you, don't take no for an answer. Go and seek a second, a third, or a fourth opinion. You shouldn't have to. But if you're not happy, because I say to my trainees, I can't call them trainees, our resident doctors, sorry, I say to them, the consultation is a meeting of experts. You are not the only expert in the room. The patient is the expert of their body. And if you're not confident going by yourself, go with somebody to advocate for you. Next slide, please. And if you're a healthcare professional, what is the stuff that you can do? Don't just listen, but listen to understand. Listen to understand what people are saying. If you don't understand the cultural nuances, there's a whole raft of resources you can get from your college, or you can get from Khan. They do some cultural safety and competence training. Like Kevin said last year, if you don't know better, do better, absolutely. And try to allow for some continuity in care. It's really hard. I work in the Far East, otherwise known as Hull. And the challenge we have there, like I was born in South London, like, who wants to go to Hull, my parents will say to me, and clearly there's some of us. But we have less doctors. We have 14% more patients than, say, Chelsea or Westminster, and we get less than half the funding. So it's really, really hard to maintain that continuity. I had a 76-year-old woman last night, metastatic breast cancer, diagnosed 5 years ago, and she said, I'm not supposed to be here. I was given 6 months, but I'm so glad I'm seeing you again. I've tried desperately to get hold of you. And I said, why has it been so hard? Because we've got lots of doctors at the moment. She said, it's just the access. So she said, but I found a way. I said, what have you done? In the morning, 76-year-old with metastatic breast cancer. She has 4 gadgets. Her landline, left hand. Her mobile, right hand. Her iPad on her lap. And her computer on the desk. At 1 minute to 8, she's hitting the speed dial on the landline and her mobile. At 30 seconds to 8, she's logging into the NHS app and I'm like, it was easy for me to get Coldplay tickets. Like, what the, you know? So we have to do something differently. The system is not working. Okay, next slide, please. 6 months after I spoke to you last, I was on holiday. And I got a text, August the 3rd, and the text said, Margaret, there's a black midwife who was just attacked by a group of people going to work this morning. She's pregnant. She was kicked in the stomach and punched in the head. The hospital are aware. Then the text started coming thick and fast. Then there was a group of trainees who were stuck in their building. There are masked men outside. They're not doing anything right now. They're just standing there. And then I got a call from my mum, because we were in Zimbabwe at the time. She said, come and watch CNN. And I could not believe what I was seeing. And there I was trying to navigate people to safety, because people were trying to get people to work. I'm like, forget work right now. We need to get people to a place of safety. The sad thing about Hull, the more you move away from the centre, we are in the centre here, the less people care. I'm just going to say it as it is. We had 100 people turn up for a counter-protest. Next slide, please. You might remember this picture with Stormzy putting his Banksy bulletproof vest on. We have to wear that bulletproof vest every day. We wake up. It's invisible, but it's there. Next slide, please. But in London, as you have all done today, you have showed up. So think about that, what you can do as a collective. Do not be a spectator, as Seti said. Do not be a spectator. I've put that song there because it is one of my favourites. You know, sometimes in our life, we all have pain, we all have sorrow. But if we are wise, we know that there is tomorrow. That tomorrow is today. And I ask you today to use this event to communicate, educate, collaborate. Next slide, please. I'm going to go 30 seconds over. What can you do to collaborate? Use this opportunity to meet someone here that you have never met before. I got an email dropped about 6 weeks ago. You know who you are if you wrote me this email. If you are here, please come and find me. And I closed last year with a Labi Siffre song. You know that one, Something Inside So Strong, for people born before 1999? And she said, when I heard that song, I realised I had not failed. The system had failed me. So let's not fail each other. Next slide, please. I know Sally's going to touch on this, but if you do anything, please, as a collective, please sign up for this webinar. It's on the 10-year workforce plan. We need your voices, because if nothing changes, nothing changes. Because if we don't do anything, we know a change is definitely not going to come. Next slide, please. So, speak up, check yourself before you wreck yourself, but rest. I can't emphasize the importance of rest. This work is exhausting. Next slide, please. And it's the last slide. No, it's not, second to last. We have strength, we have courage, we have wisdom. It's inside all of us, and I just want to thank you again for giving me the privilege to be here. Last slide. Thank you.
Thank you so much, Margaret. Thank you for that amazing presentation, for highlighting the people who died during COVID. I think that was so important, as well as the summer riots and everything. Even Angie Stone at the end, may she rest. So up next we have Ed Moses, who is the Director of Policy Engagement for the 10-year plan. I believe Sally was meant to be here, but unfortunately she is unwell. So Ed is coming up on the stage. Where's Ed? Everyone give a round of applause for Ed.
That's brilliant. Thank you very much. I was hoping I would be introduced as Sally Warren and we'd see whether you could guess that it wasn't Sally. She said she definitely sends her apologies and she's very sad she can't be here today, but I think it's good news for you in that you're not going to get the stinking horrible cold that she has. And so I hope I will do her justice. Thank you for having representatives from the Department of Health and Social Care and the 10-year health plan here. It's really great, and Margaret, you can absolutely have 30 seconds or more of my time any time you like, because that was absolutely brilliant. I'm just going to talk a little bit about the 10-year health plan and what we've been doing to date. It's going to be maybe slightly drier in some respects than the previous speakers, but actually I hope the richness will come from what we've heard so far, and will encourage you, if you haven't already, to participate in the engagement that we're doing. So let's see if this... Doesn't matter where I click it, I don't get the next slide. So you will have to see me do my Chris Whitty impression. Thank you. So next slide, please. What is the 10-year health plan? Well, it's the government's plan to fix the NHS and make it fit for the future. And there's a workshop later today that's going to be looking at 3 big shifts that we think are needed to transform healthcare. And that's, thank you very much, none of them are new. I think that's the first thing to say. So it's hospitals, community, analog to digital, and sickness to prevention. And these are things that we've been talking about for decades. And these are things that are easy to say, but difficult to do. And so I think it's worth reflecting on that as we think about what are the actions that we need to do to make this different from the previous rhetoric. And some of the conversations of some of the speakers before, I think, point towards the answer, and that's about the role that we all play in our health and care and how we can make the NHS fit for the future. There are some immediate steps that we know the NHS needs to take to improve care rapidly, but the plan's going to focus on some of that longer-term activity so that we can reform things to deliver better care for future generations. The conversation that we've been having started back in October, and it's still going on. And the intention was for it to be the biggest conversation on the NHS's future in the history of the NHS. And we wanted it to be as ambitious as it possibly could be to get the NHS back on track and fit for the future. And so this engagement that we've been doing is with the public, with workforce, with the voluntary and community sector, and with basically anyone who has a view, and I think that is pretty much everyone, on what will help make the NHS fit for the future. So, excellent. So this pretty little picture gives you a sense of the timeline that we've been working to. And over the last 6 months, we hope we've led what is the biggest national conversation about the NHS in its history. And that's included the most visible bit, which came out in October, which has been an online website, and that's for staff, for patients and the public to share their experiences and ideas. And for those of you who missed it, you may have seen it reflected in the news stories, where we had some good ideas and some more witty ideas along the lines of firing Wes Streeting out of a cannon or a Wetherspoons in each hospital. I think that latter one was one of the more popular ones. But actually, what's come through is some really strong ideas about the kind of things that people want to see the NHS do in the future. Alongside that, we had partner-led events, and that includes what we call our workshop in a box. So this was a pack of products to help local organisations hold workshops in their local communities. And we've been bowled over by the response to that, and I'll come on to that in a minute. There's been, and this is slightly different, some public deliberative events. So this has been representative members of the public coming together across all the 7 NHS regions and talking about what they want to see from health in the future, but also discussing some of the challenges and trade-offs in getting there. We've done the same with staff, and that happened in February through to March, and we've also had a lot of focus on seldom heard voices. So we've done targeted engagement activities with underserved groups, and that's through roundtables, through community events, and a partnership with the Health and Wellbeing Alliance, and that's ongoing work at the moment. This all culminates with a national summit that we've got happening, and that's next Friday, where we're going to bring together hundreds of people who've taken part in those events to date to discuss some of the issues, some of the challenges, and some of the trade-offs that have come through from the activity so far. And fundamentally, that's about some of the tensions, and I'll talk about some of the tensions that we've heard from the engagement so far. So I said we wanted to be the biggest ever national conversation. We've had over 190,000 contributions through the website. If you haven't, www.change.nhs, please do go on it and contribute to it. There's been over 3,000 staff at roundtables and workshops. We've had over 700 members of the public at some of the deliberative events. And I mentioned the workshop in a box. We've had over 650 workshops in a box, and that's over 17,000 people have participated in that. And around 40% of those workshops in a box have taken place with seldom heard voices, with groups that represent seldom heard voices. And so it's really targeted some of those underserved groups. We've also had some of the representative bodies contribute their views as well, and that's 1,600 partner organisations have come through that. So lots of engagement, lots of process, but what have we heard? So this is a word cloud taken from an evaluation of the public deliberative events, and that demonstrates some of the positive views of having the conversation about the NHS with the public. And I guess the point here is one of the tests we set for ourselves was, are we going to places and having conversations with people who have never had this kind of conversation before? And I think the answer through some of this deliberative work is yes, we did have some of those conversations. And I think the important thing to say is this is definitely just the start. This engagement activity cannot be the end of how we go about doing this kind of thing. And on the staff deliberative events, one of the things that we've heard is the overwhelming majority of participants viewed the events positively, and part of that was because it wasn't just a conversation with people who work in hospitals. It wasn't just a conversation with people who work in local government and adult social care. It was a conversation with primary care, community care and hospitals, all trying to tackle what they agree are some of the big challenges and big issues, but might have slightly different perspectives on how you go about that. And so it was a really positive engagement activity and positive response that we had to that. So what we're hearing at the moment is that there is an immense amount of pride in the NHS and support for its core principles. But there's a real frustration that the NHS isn't getting the basics right, and I think we've heard that from some of the speakers so far. You know, the idea that if you work in the NHS, you've got to, it takes about an hour to log in, quite often on your IT. The idea that from the public's perspective you need to have 4 gadgets in order to get an appointment with a GP is absurd. So please just get the basics right around access, around tech. The most cited challenge actually with the public was access, and I think a good story there with the 4 gadgets, because GP access is one of the biggest frustrations, but also A&E and dentists as well. Those who have the greatest interaction with the NHS often feel that their care is uncoordinated, which means they've got to repeat themselves and manage many different communication systems. So they're the kind of human bridge between lots of different clinicians, and that's immensely frustrating. Staff really feel frustrated that they have growing demands and limited resource that affect their well-being and their ability to maintain their professional standards. They want to be able to do a better job. And they also echo patients' frustrations with poor coordination between departments and services and say this makes their job more challenging. I see I've got 1 minute and 40 seconds left. Let's go through. I might try and do what I've seen someone do before, which is just click through really quickly the slides, but I'll see what I can do. Both the public and the staff support the big shifts in principle, but they're concerned about how the shifts are delivered. So the hospital to community shift requires careful implementation. People are concerned that if they work in the NHS, they'll be working on their own rather than in a team, and there's greater risk if they're working on their own in people's homes. And the public have the same concerns, that it's more risky not being in a big hospital. They're worried that actually they won't get to see all the right people at the right time. And so what you've got here are some of the tensions. So it's not surprising on that previous slide, but when you dig, you get some of these tensions. Around GP services, A&E and dentists being a priority for most members of the public, it's a fear that, of waiting lists for longer-term treatment. So underneath that basic access, there's still concern around that. There's support for the analog to digital shift, but the public are sceptical about the role of technology. Interestingly, we did a roundtable with younger people, and they were the most sceptical about technology, which is ironic given how basically glued to their phones. So some really difficult things. What we talk about, and actually what we've talked about for many, many years, sounds simple and sounds straightforward, but it's really difficult to do. So we've had a set of working groups, and that's helped drive the policy and draw on the engagement. We've drawn from a wide range of experts to do that work. And the first phase was about understanding what the public want and expect from their health service and what it should look like in 10 years' time. And they delivered their reports at the end of last year. And we had a focus on health inequalities, and I know that Bola's talking later, and the intention was to have that at the heart. The difference with this engagement is that it started broad and it started very, very extensively, but not with a series of proposals saying, what do you think of this? Yes, no. What do you think of that? Yes, no. Asking what people wanted to see. So we don't have to kind of reverse engineer inequalities into it. This was intended to have inequalities and how we tackle those right from the off and in every single policy that we look to implement. There's some common themes on this next slide, and that pulls out increased patient agency, maximising the use of technology, a more equal partnership, and we talked about, I know some of the previous speakers have talked about that. Actually, you know, there's 2 experts in that room, and an expanded role for the voluntary and community sector in service delivery. And then the second phase was around what's the sort of wiring underneath that we need to change to deliver that future model of care. And we had a series of technical working groups, again, chaired by a wide range of experts, not just government folk like me who sit in Whitehall. If I was doing the policy work on my own, this would not be a plan that met the public's needs. And so we wanted to go as broad, both in terms of the engagement, but in terms of the expertise that we brought into the room. And what we had coming out of this, themes around, again, patient power and choice, how we devolve and disaggregate rather than thinking that we can do everything from the centre, a digital revolution, genuinely digital first, but recognising that digital exclusion is a serious issue, and making the NHS a great employer. Because inequalities is not just about the public and patients, it's about the workforce, and again, we've heard from that earlier. Other themes coming through include adopting innovation as standard. So is the system agile enough to be ready for what's coming down the track? Agentic AI, all the new tech. So basically not getting stuck in the model of what's possible now, but being sufficiently flexible to take on board what's coming down the line. The NHS needs to stop thinking of itself as a one-size-fits-all service. So how is the NHS able to be responsive to individual and personal needs? And we need a renewed focus on prevention, and we need absolutely to do that bullet there, reducing inequalities. So the founding principle of the NHS is a service for all whenever they need it. And wouldn't that be a nice thing if we delivered it? So I think I'm going to stop there. I'm way out of time. But I hope that gives you a bit of a sense of where we've got to in the engagement so far. And I think I'll come back to one of the points I made as I was going along, which is, look, this conversation is about getting us the 10-year health plan and the policies and what we want to see over the next 10 years collectively. But the delivery and implementation of this will need that conversation to continue. We'll need local areas to contribute and to drive that delivery, because it needs to be a genuine partnership and co-production approach. So please do contribute to the website now, but also when it comes out and when it's being delivered, please do take part in the delivery and also take part in the workshop on the 3 shifts later this morning. Thank you very much.
Thank you very much, Ed. So, unfortunately, we've been informed that Wes will not be joining us for today's event, so I'm afraid to break that news to you. I know that we're all looking forward to hearing from him, but we must move on, and we must move on promptly in the interest of time. But I'm sure that a lot of you will be delighted to hear from someone who doesn't usually need an introduction, but for those who don't know, this next speaker is worth listening to. So while he cannot be here today, Professor Kevin Fenton is going to join us via video address and tell us about the London approach to anti-racism. Professor Fenton has served as London's Regional Director of Public Health, where he has been instrumental in developing and implementing transformative public health strategies that directly address racial inequalities in healthcare. His leadership during the COVID-19 pandemic brought crucial attention to how health emergencies disproportionately impact Black and minoritized communities. With an extensive background that spans public health leadership roles in both the UK and the United States, Professor Fenton has consistently
and better, so congratulations. In part because I'm at the UK HSA conference, which is in Manchester at the same time. So I'll be doing a number of sessions, presentations in Manchester at the UK HSA conference. But I know that this year's summit is going to be amazing, and I'm so glad to have the time to have this conversation with you. And yes, I remember last year those words, when we know better, we must do better. And those words have been really important to me in my own public health practice, because it says that the process of learning and developing is not just an intellectual or individual pursuit, but that process of growth, learning and development must be in the pursuit of doing better for others. And that's particularly so in our public health practice. So last year we reflected on the knowledge and experience that we developed through the COVID-19 pandemic should encourage us to do better, not only for COVID-19, but for chronic diseases, for infectious diseases, for social conditions, because we learned so much in the pandemic. This year, I would argue that over the past year, we've seen examples where we're now doing better. We have articulated the challenges of Black maternal mortality and morbidity, and we now have a range of research and programs which are being done and implemented to help us to address and to understand why Black women are 3 to 4 times more likely to die during their pregnancy and childbirth, and what we might do to improve that. Over the past year, the focus on doing better for patients with sickle cell disease and thalassemia has led to a number of programs within the NHS, and you can see the benefits of those programs in improved quality of life and outcomes for those patients. And I'm really excited that last year we've seen the focus on Black men and prostate cancer, again as a result of advocacy, data, where we're now seeing more programs available to educate and empower Black men about early diagnosis and earlier care for prostate cancer. Now, those are just 3 examples where when we know better, we can do better, and we must do better. What I'm keen to see at this summit is that of the hundreds of participants who are attending, that they're inspired by the talks, the research, the policy papers that are going to be presented and discussed, and they will ask themselves, each of us, how am I going to do better as a result of attending this summit? And what knowing better and doing better is. I would be reflecting on just how fantastic the initial summit was. It was a real moment in time to bring us together to celebrate Black excellence, to hear from amazing speakers, and to inspire people from all walks of life in different phases of their careers around the importance of focusing on Black health, and to share some of the great work which is being done. And I loved the fellowship that was at the summit last year. And it was so wonderful to meet so many old friends, new colleagues, to see the next generation of researchers who were there too. And that sense of camaraderie, of the spirit of can-do was so important at last year's summit. So I'm excited to hear about what will happen at this year's summit. Data is king, and data remains king, Charles, because it is the foundation for understanding not only the populations that we're serving and the characteristics of our populations and the needs our populations have, but data are also important in understanding the interventions which can help us to tackle those health needs as well. Data helps us to evaluate the effectiveness of the interventions that we're putting in place, and data also helps us to understand or progress towards meeting our targets. At our summit last year, I argued for, and many of the presenters argued for, better ethnicity data collection in order to characterize ethnic and racial differences. But also we need to understand the context within which our ethnic minority communities reside, live, and experience lives. So understanding economic realities, housing realities, educational and employment opportunities. So we have a more holistic picture, not just the health outcomes. So, are we doing better? I think we continue to be on that journey. In the NHS, there has been tremendous advances made in population health data, new platforms which are enabling us to understand diseases, how they're patterned within communities, and how they affect different communities. And we're using that population health data to target our activities better. And we're also seeing the use of better public health data to help us to understand the impact that we're having on population health. There's much more that we can do and much further that we can do. And I think our collective efforts, and at this summit, to have that focus on improving data and insights and how we use those data will be a critical discussion point at this summit. We have long argued, certainly in my role in the president of the Faculty of Public Health and as a director of public health, that racism is a public health issue, in part because of the pervasive nature of it and the impacts that racism has on the health, well-being, economic productivity, and life chances of individuals within our society. We continue, both in my work as regional director for London, working with our partners and health and care leaders in London, to keep a focus on structural racism and the things that we can do across the health and care system in London to tackle structural racism. And I'm really pleased over the last year that we have, through our partnership with the GLA and the NHS and local government in London, been able to fund both the work of Professor Sir Michael Marmot to look at the impact of structural racism in London, one of a major report from the Institute of Health Equity, which really shines a light on the nature of structural racism and its impact on the health and well-being of Londoners. We've also funded the London Anti-Racism Collaboration on Health Project, LARCH, which really is bringing together our partners across London who are involved in anti-racism approaches to share best and promising practice and to ensure we have consistent approaches for how we discuss anti-racism and how we implement programs within the health and care system on this issue. And as you remember at last year's summit, I introduced London's strategy on anti-racism in the health and care system, and that also is being implemented by our ICSs. I'm really excited, Charles, because in the last couple of years, we've appointed Dame Marie Gabriel as our anti-racism champion for the health and care system in London. And she, along with other leaders in the NHS, have been doing phenomenal work looking at data within within the NHS on structural racism, training and capacity building of NHS managers and leaders, advocacy with our staff around anti-racism and tackling inequalities, and looking at data within the health and care system on experiences of bullying and harassment, racism and discrimination of NHS staff. So over the past year, not only have we been through large, looking at how we build capacity in our partners, but at the same time, our NHS leaders have been implementing their own strategies on anti-racism as well. So I guess my summary of this is, yes, we can. Yes, we can develop the strategies that help us to focus on anti-racism in a much more structured way. Yes, we can look at systems and organizations and develop plans, strategies, and actions that can make a difference. And yes, we can use the data that we have from our staff survey to ensure that the lived experiences of our staff related to structural racism is actually improving, and where it's not, to take corrective action. I think this structured approach is something that we can all learn from, and I'm keen to learn from other regions which are also doing work in this space. Some of our colleagues who haven't heard about Million Hearts and Minds, it's a new pan-London regional initiative on cardiovascular disease prevention. We are developing this new pan-London program to run over a 5-year period, because we recognize that as we've exited the COVID-19 pandemic, that heart disease and death and morbidity from heart disease remains among the top health priorities for Londoners, resulting in premature mortality and people falling out of work because of ill health. So we wanted to build upon a lot of fantastic local work which is being done on CVD prevention, but to give it that focus and that prioritization as a regional priority through this new pan-London program. So it's called Million Hearts and Minds because we want to engage 1 million hearts and minds across the city on better heart health. And you're absolutely right. We are building in community engagement and mobilization throughout that program. Again, because when we know better, we do better. We did this in COVID with the vaccination program. We did it subsequently with the London vaccine and equity programs, where we worked with so many community organizations. And for Million Hearts and Minds, we want to bring that community assets, those assets, that engagement and the lessons learned to helping and working with communities to tackle and improve heart health. So over the next 5 years, the plan is that investments from the NHS and local government will be combined with and used to leverage resources from voluntary, charitable, and other funding sources to build a prevention pot that helps us to pilot new ways to support cardiovascular disease prevention and control, and to fund innovative programs where we can engage communities and support community-driven activities. This is so critical, Charles, because we know that CVD, cardiovascular disease, isn't randomly distributed across our region. We know that the economically deprived parts of the city have higher rates of heart disease, uncontrolled blood pressure, and stroke. And we know that especially for men, Black men and men of Asian backgrounds have some of the highest rates of cardiovascular disease across the city. And we need to do a lot better of engaging them, linking them to care, and helping to activate members of the public on their heart health. So we're at a very early stage in the program. We've just finished our first year, which is our foundational year. We're building the architecture for this new Pan-London program, but I'm so excited that communities are at the heart of Million Hearts and Minds, and we look forward to sharing the results of this program at further summits as we progress.
Thank you, Kevin. So we're now going to move into the morning workshops, and after that we will break for lunch. But as we do that, if you want to grab a quick refreshment before you do head into those morning workshops, then you can. They're on the way downstairs. But as we move into them, we have 5 specialized workshops available for you to choose from. These range from the NHS 10-year health plan, health and tackling racism, embracing diversity in digital health, AI, culture and ethnicity, black maternal neonatal health, black mental health and long-term conditions and cardiovascular disease. Please follow the directional signs to your workshop of choice. The room locations are clearly marked and our staff volunteers are positioned throughout the venue wearing coloured lanyards, and they'll be ready to assist you with any questions and directions you may need. Sorry, just a little bit of quiet so I can just finish this. I know you're all eager to go. Each workshop has been designed to provide you both with expert insights and opportunities for you to actively participate in. We encourage you to engage fully in these important discussions. The workshops will begin shortly, so as I said, if you want to grab a quick refreshment, then please do on your way out. And thank you for listening to this morning's speakers. Thank you.
Ladies and gentlemen, can we vacate this room for the AI digital workshop? If you are staying for the workshop, you are more than welcome. There's lots of staff, lots of volunteers outside to help you locate your workshop. We'd like to start our next workshop on time.
I don't know if anybody's explained this, the format for the workshop, how it's supposed to go. So opening presentation, I think Julie is giving that first like 5-10 minutes.
No. We have 3 speakers for our workshop.
Yes. So there'll be an opening presentation, then you speak about the importance of the issues.
No. Ignore that.
Okay, that won't flow.
We got it all organised.
Can I just make a check? Yeah, check.
Everything is going to online.
Could you turn this off?
I've changed it.
Thanks, Millie. Sorry, Millie. Not you turn it off. I'll talk to my colleague. But yeah, check. Okay, yeah. Thanks for the check. You can turn it off now.
Try to keep everybody. Yeah, it's live. It's live. It's live. See, are they using this? That's not full screen. They don't want to use that. Give me. What do you need, dude? Come.
Give them these two mics. They're both working. Yeah.
Okay.
Three of them stood there. Do you need a mic?
They'll sort of pass.
Format the slides properly. They gave it to me. So what's that? The guy that gave me the slides didn't do it properly.
What's wrong with it?
His video. You're thinking of it like that. I don't have the time. Told him. Yes.
Yeah, this is the one. Shortly.
Okay, thank you.
Yeah. I feel like they're all on. They're all on.
And this is how to switch them up.
Middle this one. Okay, this one. Yeah, it should be working. I just want to.
All right, come on.
Well, after people get to Q&A, I don't think we need them for now. We'll all use...
The clickers are on there. You want to check?
So,
on the...
we're waiting for our last speaker.
So each speaker goes to the podium to introduce.
Unless you want to...
There's a laser. If you want to use that, please don't press this button. Just use the laser. Thanks.
Okay, so don't press
the green for go.
Two.
People before you, don't worry. You're the last speaker. Yeah. Which one's you? Before then. Come on, Marion. Where's she?
Can I call her? Do you have a number?
I'll send her a message.
Do people want to move forward?
Okay.
Oh, here she comes. Good grief.
These are on.
First. We're not going to...
Yeah, all right.
I wonder whether any of the presentation slides will be made available to delegates, our email or anything like that?
I will. I assume so, but I'll check.
That'll be lovely.
I'll get back.
Thank you very much.
I just need to get...
Do I just need a...
Grab a seat. Ed. Ruchi, please come and sit down. Okay, can we get started? Margaret, it's been great listening to you. I'm going to kick you out now unless you're staying for this workshop. Okay, can someone close the door, please, at the back? patients. Just to be absolutely clear, this is the workshop you've all booked? You're all in the right place? Fantastic. Brilliant. Thank you very much indeed. I'm just going to say just a few words by way of introduction. I spoke earlier, I'm Sedi Frederick, and I wear a number of hats, including co-chairing Inspire. I'm also chair of NHS Kenton Medway, and I sit on other boards and chair other things. And I'm also the co-founder and CEO of Conciliaris Digital Systems Limited. And we are very much involved in developing AI and digital health systems that understand cultural sensitivity and cultural diversity. So we were invited to collaborate with others to bring an initial presentation to you and to also curate the Q&A that we hope will follow. We have a number of speakers today, and in order that I'll invite them to speak. Ruchi Singh is a senior associate with Conciliaris. Dr. Marianne Faroux will speak. Second, you introduce yourselves and so on. And then finally, my co-founder at Conciliaris, Ed Klinkett, will hopefully share some thoughts and ideas with you that will spark discussion. So I'm not going to say a great deal more, but without further ado, let me introduce Ruchi and invite her to say a few words to you.
Hi everyone, I'm glad to see we've got a nice big auditorium, so I'm glad that AI was the attraction, or maybe it was SETI. Either way, thank you for coming. Today, okay, is it going to work? There we go. So the workshop today is absolutely, as all workshops should be, is interactive. So while we will give you some inspiration in the first half, the second half is all down to you, so please start thinking about your questions and what you want to talk about. So as SETI said, I'll start. I'm Ruchi Singh. I'm a strategy and transformation person, professional, and I do quite a lot of work in anti-racism and healthcare. So I've worked with SETI for a number of years now on such issues. Followed, then I'll hand over to Marianne, who will talk about the potential use cases around AI and addressing health inequalities. That's pretty exciting stuff. And then Ed will show you some really interesting tech that they've been developing in Conciliaris, where we absolutely have embraced culturally sensitive AI solutions for triage, for healthcare, etc. So I hope you'll find that really exciting. So to start off with, it's not going. Oh, there we go. So I'd like you to scan this code in. I was hoping that we do that as you entered, but this is just to see what your thoughts are around and your experiences around AI. So if you could just do that, I'll give you a couple of minutes. Ed, will it show the results on the screen? On the app. Everyone managed to get onto it? It says waiting for presenter. Oh. Waiting for presenter. Oh, what do I have to do? Say again? Is that right? You have to go on to Menti. I have to go on to Menti. Okay. So you can see I'm not the tech person here. It's telling me the same thing.
It can either be user-led or presenter-led. Okay. And you can change that in settings.
Ed, I think you're going to need to do this. It's still telling me to be user-led. Maybe we'll scrap that. Okay, in the interest of time, we'll send one out to everybody. Okay, so I'm going to talk about AI. So what we're going to talk about today. So I'm going to talk about AI and the context and why it really matters. And then we'll hand over to everyone else. So why do we care? There's a lot of conversation at the moment about AI, and there's a lot of doom mongering. It's going to take over the world, and we're all going to be out of jobs. But you know what? It's not that different to when computers were introduced in the 60s and 70s or 80s, depending on how you see it, when the internet came about in the 80s and 90s, and now we've got AI. It's just a game changer. It's definitely a shift, and it's changing the pace, and it's increasing the possibilities. But actually, the possibilities that AI could offer us in terms of addressing health inequalities are really positive. I'll talk about that again in a second. But right now, we are faced with cuts. NHS England's about to go. ICBs are going to be reduced in half. Every trust is trying to work out their budget plans around how they're going to cut costs. I was talking to a CEO yesterday, and they said, "I'm cutting costs. I'm closing down one surgical facility, and I'm closing a ward." And I'm thinking, we've got unprecedented waiting lists. How can we afford to close down a ward and close down a surgical facility? What's going on? But actually, AI is an opportunity to think differently. So we could either retreat to the old way that we've always done it and just go for cuts. But actually, this is a chance to reimagine the future using AI. We could preserve a lot of the services that we have by introducing AI, not being fearful of it. Simple things, like I'm sure you guys use ChatGPT, and if that Mentimeter had worked, we'd kind of work out who is using ChatGPT or other tools. But there's really simple things. I was talking to my daughter yesterday about how you could use ChatGPT to help you learn stuff. You know, she was learning physics. It's like, I couldn't do it for her, but I could work with her to do it. Now imagine if we just introduced that technology in the way that we helped our workforce upgrade their skills in a very simple, bite-sized way. So there's the opportunity to reimagine. What Dr. Farrow is going to talk about and what Ed's going to talk about will really blow your mind in terms of what it's going to do, what the possibilities AI creates in terms of addressing those health inequalities. But as with all new technology, we have to proceed with caution. We have to be pragmatic. Let's not throw the baby out with the bathwater. Banks are using AI, and they are super secure. So if they can use it, why can't we use it in the health sector? Yes, let's not start with all the patient data. Let's start where we can really make a difference and control the privacy and the respect of our patients. But we can absolutely embrace it. What's stopping us from the CEOs and the leaders I'm speaking to in the NHS? I feel like there's a lot of fear, but right now, if our leaders stay fearful, if our community leaders stay fearful, if our patients stay fearful, who's going to lose out? Our patients are going to lose out. We're not going to be able to address health inequalities. We absolutely have to embrace it. So let's start. And I'm going to tickle your taste buds with some tech that Conciliaris have created. Okay. Oh, it didn't work.
Hello, I am one of CU's AI health assistants and companions.
Oh. So that is...
Hello, I am one of CU's AI health assistants and companions.
So what this is showing you is some culturally sensitive healthcare assistants, which could become the face of your front end for when you start interacting with health services. It was in 3 different accents, so including an Indian one and I think Nigerian one.
Hi, I am Samantha, one of CU's AI health assistants and companions. How can I help you today?
Hello, welcome to a new era in healthcare where AI avatars like myself are available to offer assistance with your health needs.
So there, hope you find that exciting, but there's more to come with Dr. Farrow and Ed. So I'm going to hand over to Dr. Farrow now.
Hi, my name is Marianne. I'm the Chief Medical Officer at Health Innovation, Kent, Surrey and Sussex. I have a fantastic job. I'm very lucky. I get to play in the future space. What could healthcare look like, tomorrow? And that's really exciting. And of course, AI and digital are going to be the future. It's here already. Anyone who's got a smartphone, anyone who has kids, will know, how much of life is now at your fingertips. And so how is that going to kind of influence how we deliver healthcare in the future? And the thing that I'm particularly interested in is how do we stop the widening of health inequalities by those that already have a lot and have huge access get more, and those that don't have access to this technology get less and get left behind. So it's a bit of a whistle-stop tour in the realm of AI, but essentially I hope that we'll have some basic understanding of what AI actually is. I'll present you with some community insights. I provide you with a bit of a case study of where somebody's got it right in terms of the technology development, and then we can have a bit of a discussion as well as part of this workshop. So what is AI? I think, this is a great summary. It's a really good definition. So we're talking about artificial intelligence. So it refers to computer systems or software designed to perform tasks that usually require human intelligence. And the task that we're talking about today is very much around the building on the data. So making decisions, solving problems, and recognizing patterns and speech. So again, take a photo, you're welcome to read that. But where AI becomes a bit confusing for people is that it actually incorporates a number of different things. So within AI, these are the four components. So we're talking about robotics, process automation, we're talking about algorithms. So when you might hear about algorithms like on social media, and that kind of changes what you see within your TikTok or within Instagram. We're talking about machine learning. So we're thinking about ways in which machines learn from very, very large data sets. And then the last one is this natural language processing. So it's things like ChatGPT. So again, it's kind of AI really responding and replying to you in a way that's much more human than it ever has before. And AI is already being used in some places within healthcare. And I think that's quite interesting. So it might feel new to you, but actually there are a number of different places that it's already being deployed. So for example, when we talk about predictive AI, there are a number of ways in which that's being used to start to look at the data, the patients that might be at highest risk, enabling some of that early intervention. So if you know that a patient with a certain demographic profile or with a background of certain conditions or diseases might be a much higher risk of admission to hospital, you might be able to deploy this type of AI that just kind of works in the background of your data and then gives you a list of names which then you can give to healthcare practitioners to then provide some early intervention care. So super, super helpful in that space. We've got operational AI that's certainly, again, helping with the efficiency of operations, so predicting demand around patient flow, things like that. We've got expert systems and clinical decision support. So in primary care, there's some decision support that's kind of being enabled. Things around e-triage that you might have heard of. And then we've got this generative AI. So you might have heard about ambient speech AI. So AI running in the background of a clinical consultation, and it's picking up what the people are saying in the room. So it's picking up what the patient says, it's picking up what the doctor says, and then it's transcribing the whole conversation and putting it straight into the clinical notes. On top of that, it may write you a letter and also send off your blood tests and do your diagnostics. So, potential game changer in terms of the efficiency for clinicians whilst they're in practice. But AI, as we've already sort of heard, there are some issues around trust. Like, how can I trust that this is, this is safe, that it's going to do the job that it needs to do? How can I trust that it's fair, that it's inclusive? So we know there are issues here. We know that a lot of AI is trained on data that is not necessarily inclusive of everybody. So the data that we're talking about is often generated through trials, clinical trials and research. And we know that those people who are not really part of that patient participation in the research are mainly people from ethnic minority groups and women. Most of that data set are a certain demographic of white men. So if the AI is learning off these data sets that are not representative of the population, you're going to get inbuilt bias, particularly around gender and race. But there are things you can do about it, and there are things you can mitigate and prevent for it. But if you're not aware that the data you're building your AI on could have this bias, then you are potentially in for lots of problems down the line. We need much more accountability and regulation. At the moment, pretty much anyone can start anything. And, you know, we don't have the legislation in place and policies in place to really regulate AI to a robust governance level, and that's something that people are working on. But the speed and pace of this technology is going so fast that we're struggling to catch up in terms of regulation. And then the final part is really, really important around transparency and explaining to people. So if you've got this ambient AI picking up on my conversation with my doctor, did somebody inform me, you know, of that was happening? Do they have my consent? How does that consent work in that space, you know, and how is that delivered? How is the information delivered to patients before they actually get to the doctor's office and you're kind of confronted with, well, I've got this AI running. Well, I haven't really had time to ask questions. I don't really know what it is that you're doing or talking about. So we decided to do some work with Sylvia Stevenson around gathering some community insights to really find out what women thought about AI. And so we led a group with a fantastic community in Berkshire, 32 women from Afro-Caribbean backgrounds, really wide age range. That was really interesting. And we put them out into small breakout rooms to just get some insights as to what do they think about AI and how it was being used. And so these are the things that sort of came through really strongly as themes. So people wanted to know around their education. So what information is there around what's being developed in AI? Is it inclusive? So as I mentioned before, particularly around gender and race. How culturally competent are the people that are designing and developing AI, and also the clinical practitioners who are deploying AI into clinical services. And this final part, again, is building the trust and transparency when we're actually using that technology. And I thought I'd just present a quick case study around where it's gone right. So when I talked to you previously around how do we start to use this technology to actually address health inequalities rather than widening them, this is a great example of an app developed by Tommy's, and it was aimed at addressing the major issue around maternal mortality for black women. So what they did was really around developing a digital app and specifically using the AI algorithm on their data set that reduced gender and racial bias. I think that was really important. And really to facilitate these kind of personalised care pathways that really met individual women's needs. And this is how they did it. So they took a co-design approach, and it's really important when we're talking about AI design development that we actually listen to the voices of those that will be the end user of the technology. So it could be either the clinician or it could be the patient. So incorporating what their needs were and their cultural sensitivities into the very early design of this app, bringing in experts, you know, from midwifery and obstetrics, looking at the evidence base. So there are evidence bases around digital technology and making sure that there is strong sort of evidence around what you're doing and it's not just kind of being thought up, you know, on the side. Putting in an AI risk assessment. So again, recognizing that there is this risk of bias, but let's put an assessment in to make sure through all the stages of the process that we're looking for it. Education and training was critical. So I think we'll probably probably have a bit more about digital literacy, but 1 in 8 NHS workers have very poor digital skills. So this assumption that everyone, even who work in the NHS, can use digital is wrong. So there's a lot to do, as well as ensuring that our patients also have literacy in being able to use the technology. And the final part is, as with any improvement, there should always be some rigorous evaluation and monitoring. So the key takeaways for me are really around that digital innovation has a huge opportunity in this space to actually address health inequalities. We need to be mindful around patient safety and ensuring that the things that we're designing actually meet the needs of our patients, that we think about collaborating much broadly across the space, and that can be with academics and clinicians and with groups of patients to ensure that their voice is really loudly heard, and fundamentally addressing bias, because we're not going to be able to reduce health inequalities if we're not thinking about the potential bias that exists within everything that we do. That's it from me. Thank you.
Thank you, Ruchi. Thank you, Marianne. I'm the geek in the room, so I'm going to try to do minimal speaking. But the initial discussion earlier should give you an idea of what is available in AI today, and also what key concerns exist, and valid concerns. So what we've done at Conciliaris is taken those concerns and looked at different ways of applying the technology in a way that is usable but can also be scaled. What I'm going to do is take you through a couple of scenarios from the perspective of a user, and then also from a perspective of a clinician using one of our avatars. So in this scenario, we believe that AI can help us build the trust and effectively reconnect us with the system. And one of the best use cases is for us to interact with an AI that answers our healthcare questions and needs, and we can do that. We've developed an app that allows us to speak to that AI, and you'll get a response. Forgive my slow typing. I was doing this.
I'm sorry to hear that you're experiencing sharp pain in your left arm. Could you please tell me if you are also experiencing any other symptoms like chest pain, shortness of breath, or dizziness?
So what we've done is we've taken technology and applied real-world physical scenarios to it. And the avatar that you're seeing there is responding to prompts.
Do you have any other symptoms like chest pain, dizziness, or nausea? I'm sorry, I didn't understand your response. Could you please clarify if you are experiencing any chest pain or dizziness along with the sharp pain in your left arm?
My typing is not very fast.
I'm speaking.
So what you're seeing in that AI, I'm going to put somebody in the spot.
Based on your symptoms of sharp pain in your left arm and feeling a little short of breath, it's important to consider seeking immediate medical attention, as these could be signs of a heart-related issue. I recommend you call emergency services or go to the nearest emergency room for a thorough evaluation and appropriate treatment. It's better to be cautious with symptoms like these.
So that's our AI working. Let me put somebody on the spot. That AI was actually developed with our very special chief medical officer as a guinea pig. Bless her, she's given me a lot of the prompts and directions in developing this, but it's based on a real person, right? And we know there are numerous tools out there where you can chat with bots, etc. What we've done differently at Conciliaris is applied real personas with real empathy and effectively extended the algorithm to be smarter. The next set of slides are effectively going to show you a scenario of us applying another AI, another avatar with
I'm sorry to hear that you're experiencing a headache. Let me help you assess the situation so we can determine the best course of action. Could you please let me know? How severe is the headache on a scale of mild to severe? Are you experiencing any other symptoms such as nausea, sensitivity to light, or visual disturbances? Do you have any difficulty breathing or a persistent cough? Your answers to these questions will help me better understand your condition.
So the same kind of technology, different face, different accent. And so we can expand this in so many different ways. I think one of our products currently translates to about 150 languages. So the use case application for it is endless. All we need to do is apply it in a way that is actually useful for those using it. And one of the things that we think will drive this, I'm not going to call it a revolution because I don't believe it's a revolution, but the adoption and trust of systems like these is the more people that use it, the more people that interact with it, we get the correct data so we don't have to deal with systems that are automatically biased, like Dr. Marianne was mentioning, because the data is absolutely crucial. The more we know, the more people of our culture and diversity use the product, the more the data is going to be accurate and reflective of the truth. So we will take those data sets, apply to the systems so there's an equal parity. So, I mean, I don't want to bore you with the tech, but there are situations where the code that drives AI, we know it's Caucasian biased, but you guys don't know the level of how biased it is. It's to the point that, for example, lip syncing technology assumes that an AI is culturally diverse if it increases the size of its lips. Right? That's how bad it is. So we've eliminated that in Conciliaris, in the systems that we do.
CU Mobile is a powerful healthcare
application. Glorious Opus.
It provides users the
and this is one of our mobile apps.
access healthcare services at any time in any of the main languages.
A patient set up in CU will have access to all their important medical and vital statistics only visible to them through our secure app. Once the patient record has been created, they will be able to see a 3D avatar that resembles them. Interacting with it is as easy as pointing to the part of your body where you are experiencing an issue. Then it is just a case of answering the questions on screen until the triage is completed. The AI will prompt and guide you all the way and even check your GP's availability so that it can provide options for appointments that you choose. Our intelligent booking system helps to reduce and eventually eliminate those costly no-shows.
Those are our AIs, some of the examples. Now, one thing I want to call out, the only real person in those three examples was Opus. The others are completely system generated, except with the difference that we've given it instructions to think about culturally sensitive prompts, skin color, tone, and also the voice. And voice is another big problem, but it's getting there. So like the interpretation of accents and different languages across the spectrum, it's very hard to get properly trained voices so that we can teach the AI. And that's effectively what we're doing in our space. And we believe that AI is here to stay. As much as I have a different relationship with AI, I've been doing it since 2010. The reality is it's going to go into a different level and a different spectrum in the next few weeks, let alone a few months. So the question is, are we prepared to influence the change and the pace now, or do we wait for the problem to exacerbate later and then worry about fixing it? You know, what we're saying is, let's do it now, let's fix it now, before the problem hits the next generation, and then it's too late for us to fix. So that's
Where's the microphone for you? We need one for the audience. Ruchi, Marianne, Ed, thank you very much indeed. Can I invite Dr. Opus to join us at the stage? As Ed said, the AI avatar that you saw is based on a real person. This is our Chief Medical Officer at Conciliaris. Opus, thank you very much for joining us for the Q&A. I should have declared an interest. This is my passion project. I love the NHS, committed to the NHS, but this is what I believe is really very, very exciting. One of the things that we learnt through the COVID pandemic, especially when we got to the vaccine rollout, and we saw that people from our backgrounds, our community, were not coming forward for the vaccine, was they didn't trust. And Marianne talked about the importance of trust. Margaret talked about the importance of trust. Seeing people who look like us up there, who have our accent, our language, I think will help build trust. So we've got about 10, 15 minutes or so for questions. I'm going to do it rather randomly, forgive me, and then turn to Ed, Ruchi, Marianne and Opus, and no doubt between you, you will decide who's going to answer. But somebody will answer. Okay, there's a lot of hands going up. Bayo, you're going to have to do a lot of running around.
We'll take it one side to the other.
Do you want to start
that way? That's where I'm going.
Well, I've done this before, and generally speaking, it's who put their hands up first. But anyway, okay, this gentleman here, and then we'll take a couple on this side and go back. We've got two microphones. So Sam, get ready.
Sam, you take the...
Apologies to...
Can you say who you are and where you're from?
Right. I'm Tonye Sikabofori. I'm from Birmingham. I'm one of the Deputy Chief Medical Officers in the Community Trust. But I'm also the chair of the Bletcher ICS Task Force in Birmingham.
Your question, sir?
So my question. One of my colleagues did some work on skin tones, especially for ulcers and things like that, of course, So I think I'll go straight to it. Would this be an area where AI will support, especially it's difficult, as you know, to, as a doctor, making diagnosis, where I was taught in medical school, basically to make diagnosis on mostly, from the textbook, white people. Although I trained also as well in Nigeria, so of course I know that. But coming to train here, it was difficult because then I had to do away with some of those practices I had. So yeah, it's just a quick question to the panel.
Thank you.
Yeah, so I can answer that. So where AI is probably had the most investment is around diagnostics, particularly dermatology, radiology, pathology. So dermatology, there are a number of different AI products out there. One of the most well-known is Skin Analytics. It's for skin cancer, has been very well evaluated and been shown to be more accurate in terms of its diagnosis of skin cancer than a human. But, and I know, you know what I'm going to say, but of course that's mainly in light or white skin tones, okay? And so what we need to now do, because it's being deployed across nine very large trusts, is build the evidence and the data. So the data doesn't exist. There isn't enough data from very dark skin tones for some types of cancer. And so we need to build that evidence base. But it is already being deployed. So again, there's sort of this ethical question of, do we wait until everybody can be included to deploy something? Or do we deploy it sort of half done, but understanding we're potentially widening inequalities for some groups? And I think that's, at a very senior, national level, those are the kinds of conversations that are happening. But in terms of skin ulcers, that would be the next one, yes, lots of technology. So where AI is great is pattern recognition. If you're a clinician and you're quite an average clinician or not a great clinician, AI potentially, the decision-making tools, could supercharge your clinical practice to be brilliant. If you're already a brilliant clinician, it's not going to add a lot. But if you think across the whole of the NHS, how many, I mean, if we sort of think of a bell curve, you know, the far end portion are brilliant, the rest are kind of in the bell curve. So that's the, you know, the 80-20. So 80% of our clinicians would probably benefit from a decision-making tool. And so that's why it's exciting, and that's why there's a lot of development in that space.
Thank you, Marion. Thank you. Sam, have you got one there, please?
Hi, my name is Mohammed. I'm from Guy's and St. Thomas's. I work in EDI. So I wanted to ask you guys it's two questions, but it's based around trust on AI. So the first question is, you know, OpenAI have been saying like artificial intelligence is getting to a stage where it's kind of strategically lying, for example, in certain cases. How do you guys mitigate these types of scenarios, or have you been thinking about that in terms of its ability to do that? And the second question is more about messaging in terms of AI. You know, we work across the trust. There's this kind of reluctancy in terms of adopting AI, in the sense of there's a lot of negative messages about, oh, AI is used for, you know, let's say, for example, researchers writing up stuff using AI. So there's a lot of negative message. What can we do to kind of look at the benefits of AI? Because it really does have a lot of benefits, but there are some risks as well. So I wanted to pose that to you guys.
Thank you.
I'll take the first part. So AI doesn't lie. That's the truth, because AI only repeats what you give it. So effectively, if you give it bad data, it's going to give you bad answers. Now, the reality of that is how we interpret it. If you think about AI exists today, you know, it's not actually that smart, to be honest. It learns from what we tell it. So if we continue to tell it that A equals C and so on, it's always going to know that and recognize that as a pattern and continue, et cetera, et cetera. I think what's important for us to build that trust is make it self-check, and that's one of the things that we do in our AI algorithms, is it queries itself, and it's very controlled in how it interprets the data set. So, for example, when you're answering the triage flow, it's based on MTS3, NHS standards, et cetera, but it self-checks to see, has it considered every possible permutation and valid answer, then it provides the response. So it's all about how you adopt and apply controls in how you develop it, pretty much. Because what we don't want, and we know some of the results are ridiculous. You ask GPT some things and it'll spit out whatever. But you have to be conscious enough to challenge that and ask it to go back and check. Because if you don't, what happens is it doesn't self-regulate. It'll just carry on doing it. So it's also about usability and learning for us. It's easy for me to say because I'm a techie, but for you guys as users, querying every single step is just good practice. It'll be better, it'll be more informed, it'll learn from the history, and also recognize that not all AI tools have memory built into it. So if you ask it one question and then repeat the question again, it's not going to know how to go back. So there's little steps that we need to learn as users to continually challenge and challenge and challenge until it gets to a point where it offers accurate and valid responses. So in terms of the messaging, I think scaremongering will always exist, no matter what. I mean, I've been in tech for so long that I started before the internet, right? And everyone said, oh, this is going to destroy everything and yada, yada, yada. And today I'm talking about AI, right? Which is like different parallels. But if we define and create the right supportive messaging, these tools are here to help us, not to hinder us. That's my view.
Thank you.
Can I just add to the messaging point? So I think as a sort of transformation person, I work a lot with organizations in trying to help build their trust and confidence to transform, and more so get behind the transformation goal that we're trying to achieve. And the organizations that I talk to about AI is still in that evidence-based approach, in that when Excel came along, Excel wasn't going to fix it, and there was a lot of doom mongers thinking, oh, I'm not going to use Excel because I have my trusty calculator. But where I see the real benefit around the messaging is the proof of it is the proof of the pudding is in the eating of it. So it's create those simple use cases and compare it to the original. So take a simple use case around a board paper. How would we create a better board paper with the right messaging that's really succinct, really able to do the messaging, and compare that to a human or a series of humans writing that board paper, and then analyzing it and say, look, is this working for us? Is this serving us better? Is it allowing us to redeploy our staff to the other frontline activities that we need them to? And then just getting people to understand there is value here. So you can tell people till you're blue in the face, but until they see it and feel it, they won't believe it, and then they won't try, and therefore you won't create trust.
Thank you very much.
Hi, good day, everybody. Thank you very much for that lovely and informative presentation. My name is Dr. Renee West, and I work with a London-based HIV charity. And what I wanted to just let you all know as well as ask a question about it, is that we developed UK's first sexual health chatbot. And one of the reasons we did this is because we wanted to, like you were saying, don't forget the name, it's basically so that our staff could be deployed to do other things. So what this chatbot, it's available 24/7, and you could go on our website and you could access information about sexual health. You could book HIV tests and other STI tests. It's also used by 3 NHS, Derbyshire, Hertfordshire, and Southwest London. But it is a chat bot. So, and just also to mention that as far as our website, we get about 150 users on it per month. But what I'd like to ask is how do we, it's animated, it's not like your avatars. So how can we make it more culturally friendly? I'm not an AI person, so I really don't know.
I guess you just talk to Ed, really.
Yes, find me after.
All right, thank you. Sam, is there one on that side?
Thank you all very much for the presentation. Dr. Rodney Reynolds from Lambeth HDRC and also UCL. 3 quick questions. Number 1, why don't the avatars blink? Makes them look very creepy. Question number 2, what does this look like in clinical deployment? We obviously know that kind of going into a clinical space and having a physician who's looking at a computer screen and typing up notes rather than looking at you doesn't support the sense of active listening. It doesn't encourage trust. So what does this look like in clinical deployment? And then number 3, I recently set my students in an ethics class the task of selecting published research papers, and they needed to have a debate with the most recent version of ChatGPT through at least 4 iterations about the ethics of the paper that they had selected. And one of the things that we found that was quite surprising is that I encouraged the students to take up an oppositional stance to whatever they were getting from the chatbot. The chatbot eventually comes back around to reconciling with the student's view. So there's kind of a default here to telling you what you want to hear.
Thank you. Now, I'm conscious of time, so there's a lot in that. I don't know about the blinking. I mean,
that's a quick one. It's really hard to code blinking. Very hard.
But I think the really important question there was about the engagement and what we're asking technology to do. I don't know, Opus, do you want to comment on that?
Yeah, I'm happy to comment on that. So
I think from our standpoint, this is very much a tool to facilitate access to healthcare. So we've talked a lot today about access being poor to healthcare services and someone having 4 devices just to be able to book a GP appointment. Instead of that, it could be this AI assistant that you would message to say, these are my symptoms. They can screen to see if there's anything that would constitute a medical emergency rather than a GP appointment, and actually be able to go into the diaries and book that for you. So I think from that standpoint, the way it would fit would be helping to increase access to healthcare by bypassing some of the issues we have with access and waiting lists and I guess low human resources or understaffing in some areas. Another thing as well is during consultations as well, if you've already kind of had this conversation with the chatbot previously as well, coming into, you might be more informed about your symptoms, or it could tell you where would be most appropriate to find help. We went through some iterations of asking the AI assistant, where can I find dermatologists in my area, for example, or what kind of healthcare service would be most appropriate for the symptoms that I'm exhibiting, or where do I get more information about this? So I think it fits in terms of also empowering patients as well, and in terms of health education and health information from that standpoint.
Thank you. And just to add, back to this trust thing, Ed, you're talking about how many languages we can program this thing to respond to. And it's not a case of replacing clinicians at all. But if you're able at 2 o'clock in the morning to engage with someone who looks like you, just perhaps in terms of going through these symptoms, that's going to help, we think. You know, and the chatbot versus the avatar, again, it's just that sense of connectivity. But you will start coding, blinking. That's your next task,
Yeah,
Mr.
if I can get the server resources. I just wanted to add one thing about the circling back of questioning. It's every single research paper that's been published is in a chatbot at some point, right? How you ask the question is always going to be based on what you're trying to find answers to. The AI is not smart enough to distinguish question variation, and ChatGPT 4.5 with the research model today is supposed to do a bit better, but it still lags behind MATLAB's entire research engine, right? So there's lots of things that can be done. I think it's just pushing and pushing for better questions and answers and interpretation of those results.
Thanks, Ed. Mariam, very quickly.
Just quickly, I think it was just on the point that you made about the ambient speech, and I think that we're not great in health at measuring things either, or measuring the right things. We do a lot of data collection, but not the best evaluation of things. And so we've got a number of different pilots that are already in place with ambient speech across primary care, secondary care, community care, using Heidi and Tortoise are the two companies that we've engaged with. And what's interesting is that, initially the data we're collecting is, well, how many minutes did you spend less, in the consultation, or, how many times did you have to open up the medical record, or, so it's very bean counting. But actually, the really important metrics that came through were the clinician and the patient experience. So the clinician actually said, I felt I wasn't distracted. I could really listen to the patient during that consultation and really hear what they were saying, and had a much better understanding of what their needs were. And the patient also felt that they were listened to a lot more. So it took the noise of the doctor sitting there in front of the computer screen typing into the medical record, and actually became a much better consultation for everybody involved. But they weren't the initial metrics that were being recorded. So I think there's also some work there to do on where the value add is in some of the consultations around AI. And then the final part is just really around the chatbots and the virtual assistants. And if you actually start to look at some other countries that have deployed AI a lot more than we have, so for example in South Korea, they've actually got their avatar similar to this doing mental health consultations. And having a full CBT, cognitive behavioural therapy session happening, and really good results from that from a patient's perspective. And although that might seem really an alien thing to do, like I actually really want to speak to a human, there's a lot of stigma involved around mental health, and so actually being able to engage with somebody that's not a human has been also found to be beneficial for some people, and that was interesting.
Thank you very much, Marianne, for that. Conscious of time, I'm afraid we've only got time for one more question.
This is right in front.
Right.
Yep. She had her hand.
Okay, of course.
My name's Gloria Brown, and I'm not a doctor, I'm just an ordinary person. And just in terms of the AI, I've been using it for probably 2 years, and people think I'm crazy, but I think it's actually some good things about it. What I find confusing is everybody says put it on your phone as an app. Well, very often I haven't got enough room to put an app on, and I think you need to bear that in mind, that people don't have all those luxury phones that you're assuming that they have. And the second thing is the messaging that comes through all the time. It's quite personal, and it can be quite upsetting, especially when they say you need to get your heart sorted out or whatever. It comes in just like nightmares, and the timing of the days. And just assuming that people don't understand the technology. We need to be out there in the community talking to Joe Public about things, and just assuming that they don't do AI. We need to have that human contact. I find that just in terms of the phone, it's quite clear that it's an AI automated message, but it's just ridiculous. Press 1, press 2, press 5. Are you having a heart attack? Well, yes, I am having a heart attack. I need you now. But, you know, I mean, this is just logical things, and I think one needs to talk to people. It's so evident because we're so overwhelmed, and we're dealing with the COVID situation. We're still recovering. And please just bear that in mind. I just wrote something else down. What is blinking? You're talking about all this stuff. What is blinking?
Your eyes blinking when you're closing.
Oh, is that what you're referring to?
Yes,
eyes on the model blinking.
Thank you very much. Thank you for your question. I think it's really important, and it goes to the heart of what Inspire is aiming to do. Why we were set up as Inspire, it was to connect with communities, connect with people who, with the greatest respect to people in the workshop today, who are clinicians, who have an NHS background and so on and so forth. It's really important that the whole Inspire movement, as we're now terming it, really connects with individuals. We recognise that not everyone has a iPhone 16 and so on and so forth. So we've got to find ways to connect with people differently. But I think what the message that I hope is coming across is we have to engage with AI. We have to own it. Because if we don't, the people who do own it will not really consider us. So that's really, really important. And I'd like to think that the work that Marianne is doing, Opus, Ruchi, Ed, and not me particularly, I just in the way, is starting that conversation. So thank you very, very much for taking part in the workshop. Please thank the speakers in the usual way. Thank you.
Thank you, Sedi, and thank you to the panel who just joined us for that. So we've now reached the midpoint of the summit, and it's now time for lunch, which has been laid on downstairs. Lunch is available in the Cambridge and Windsor area. We have 1 full hour, or just under that, until 1:35, and then we'll be back for the performers activity, which should be back in here. So obviously lunch is an excellent opportunity to go and network with people, take on today's reflections, and connect with people that you may want to speak to. Staff and volunteers are available if you have any questions that you'd like to ask about any dietary requirements and any assistance you might need. And our afternoon session will begin promptly at 1:35, so please ensure you're back in the main hall by that time. Thank you for your participation this morning, and please enjoy your lunch.
welcome back. Welcome back to the summit. Please take your seats. Today, sorry everyone, if you'd like to start to quiet down a little bit, because I'm about to introduce to the stage, we have a great performance by One You the Magnificent. This group brings together the powerful rhythms and vibrant traditions of African drumming to life through their electrifying performances. Feel free to take part and participate in this. Give them a round of applause. One You.
There's no audio. Move the audio.
I hope you're all feeling energized after that and speaking into the second half. So now it's my great pleasure to introduce our keynote speaker, Professor Bola Owolabi, Director of Healthcare Inequalities at NHS England.
Wow, thank you all so much. Thank you for that very warm and very kind welcome. It's great to be here. I bring greetings from Cresswell. How many people know Cresswell in this room? No? Okay. Well, I'll have you know it's a very beautiful village in the northeast of Derbyshire. And we do have the Cresswell Crags, which is a network of caves from prehistoric times. So you might want to come and visit us. That's where I'm a GP, and I always do want to remind everyone of the fact that I do have the distinct privilege of working still at the front line in some of our most disadvantaged communities in the country. And I say that because I hope that, you know, the conversation that we have is not a policy conversation, but a people conversation, because people experience health inequalities in a very real way. It's not the papers, it's not the strategies, it's the actual difference that we're able to make together in people's lives. So thank you again to LDNinspire, to Caribbean and African Health Network for once again hosting this summit this year. You'll have to wish me luck because I'm a technophobe, and I do hope it all works according to plan. I just want to start my remarks by acknowledging the fact that we've just noted the 5th year anniversary of the pandemic. It's not that long ago, actually, and I was listening to a speech recently, and the speaker painted such a visceral picture of the pandemic that I found myself taken back, actually, to 2020, and how it actually really felt, not knowing what is this virus. Is it a virus? How is it spreading? You know, and the absolute panic that we all felt one way or the other. And that reminder actually made me decide to do some reflections today and to talk about what has changed in the intervening period since then. So the pandemic was 5 years ago in terms of when it was declared formally, and the program that I lead in NHS England is 4 years old. What has changed? The so what? Because I remember speaking in many forums back then and saying one of the things that the pandemic has done is to shine that harsh light on health inequalities, and that the greatest legacy that all of us must leave going forward is to narrow those health inequalities. And I felt we've had 4 years. We've had 4 years actually in which to turn that rhetoric into some sort of reality. And therefore, I just want to talk about the progress that we've made, but not in isolation, but in partnership. Many of you would have heard me say that the answer lies between us. And so how have we been able to drive the answer between us? I came across CAN for the first time at the height of the pandemic, when we were looking at the data, and I was alarmed that when you looked at who was dying and you looked at the vaccine uptake, it was an inverse relationship. The vaccine uptake was lowest in the communities that were dying the most. Black African, Black Caribbean, our Asian communities. And I remember the valiant effort of CAN. We were together in all kinds of forums, talking to community leaders, to faith leaders. We were there with the Minister for Vaccines at the time in endless focus groups, appealing to people, begging on occasion for people to overcome their fear and to help us turn this ship around so that we stop seeing the ghastly data of how people were dying literally in their thousands, and to please come with us on the vaccine journey. I reflect on that, and I want to salute and thank CAN for all that they did in those very dark, bleak days to meet people where they were, to speak a language that people understood, to acknowledge and to respect people's fears, to be there at people's doors, to be there on the streets, explaining and answering in a respectful way, not dismissing people's fear as mindless hesitancy, but acknowledging people's legitimate concerns. And it wasn't just during the week. They still run this Black Health Network meetings every Saturday. And I remember back in 2020, December, maybe they had one weekend off. That was it. I share this story to say, we all, as you've heard me say many times, have agency to act. CAN did not wait for the agencies to change. They got on with it. And I salute them for it. Thank you. I was rather hoping you'd do that. The other thing that happened, and I'm so delighted to see Professor Habib Naqvi in the audience, the CEO of the NHS Race and Health Observatory. The other thing that I will always be proud of having been a part of was the establishment of the NHS Race and Health Observatory. Because as the data started to come through our TV, and we began to see that actually the pandemic was not a leveler, we began to see that we were not weathering that storm the same. The question was, so what? Because we could have continued with an endless admiration of the data, but I will forever be grateful for the leadership of people like Simon Stevens, the then CEO of NHS England, Lord Victor Adebowale, and others who looked at the data and said, we must have an answer. And the NHS Race and Health Observatory was born. And all of you will have seen the valiant efforts they've made in their 4 years of existence, to shine the light on the inequalities, to influence the policy, and increasingly to drive change in real and practical ways. For all the darkness of the pandemic, I just wanted to call out the things that we've been able to do. Out of the ashes of the pandemic rose the NHS Race and Health Observatory and all the work that it's driving forward. And as that period continued, I spent a lot of time talking to people, many of you in this room and other organizations, to try and understand what is it that we can do. Because every call was started with the life expectancy gap and the healthy life expectancy gap and all of those big statistics that we're all very familiar with. I was looking for hope. Because actually hope is the power that keeps us going when all is bleak. And this vision statement emerged from the hopefulness of many people, that the thing that we can do is to collectively drive behind this vision of exceptional quality healthcare for all by paying attention to three things: the equity of access, the quality of people's experience, recognizing that it's the combination that leads to optimal outcomes. We were able to create together a powerful, positive, and compelling picture of the future, despite the bleakness of where we were. I share this to say that one of the jobs of leadership is to be able to sell hope, even in the midst of adversity. This vision was first shared back in March 2021, right in the depths of the pandemic. But we didn't just stop with putting together a set of words on a nice sheet of paper. We recognized that for that vision to become a reality, we all needed to go on a journey of changing our minds. And one of the things we needed to do was to stop looking at health inequalities as the too difficult to do pile. It's very complex. We don't know what to do. We don't know where to start. We had to collectively undergo a mindset shift that moved health inequalities from the too difficult to do into the eminently doable space. We had to make a shift from a retrospective tick box exercise. I have completed an impact assessment and health inequalities have been dealt with. You know, Sedi is distracting me. He knows it very well. He sits on all sorts of boards, and he would have seen lots and lots of reports saying, and we have conducted this impact assessment, be rest assured it's all sorted. And we've had to move from that tick box, retrospective, unhelpful exercise into actually being proactive and thoughtful in a very meaningful way. Have we actually considered those at the margins? Have we actually considered the people and the communities that don't fit neatly within the bell curve? The people who find themselves at the peripheries in a proactive and meaningful way. We had to move from what Rob Webster describes as the eternal admiration of the problem of health inequalities, where we collectively were suffering paralysis by analysis, where we were all public health experts and we could reel the data off our fingertips, into the space of what are you actually going to do tomorrow that will make a difference in the lives of the people of Cresswell. And it was that movement, that mind shift from the admiration of the problem and the description of the problem into actually creating solutions that work. And finally, we needed to move from making grand statements, prosaic statements of utopia with absolutely nothing behind it. We had to move from that into actually having a strategy for action and having some specific interventions that we were going to take forward. This is the journey that we've all been on in the 5 years since the pandemic. The other thing we needed to do was to stop us eternally saying we haven't got a clue where to start. And so we set out these 5 strategic priorities that as we emerge from the pandemic, we must restore our NHS services inclusively. Whether it was in terms of electives or in terms of urgent and emergency care or general practice access, whatever you put in that box, restore NHS services inclusively. To include those at the margins. We said mitigate against digital exclusion. Because I know, like many GPs and others across the land, we had to pivot to a digital way of working. The virus necessitated us to pivot. But actually, not everybody can come on this digital journey at the same pace. And there was the imperative to look in the rearview mirror at those who were being left behind. So we said we must mitigate against digital exclusion. The third thing we said we must do is to make sure that our data sets are timely and complete, especially ethnicity coding. Because one of the things we learned at the height of the pandemic is because we had emergency powers, we could bring all kinds of data sets together that got us to 95% completeness of ethnicity coding, and that mattered. because it meant when we were disaggregating the data about the vaccine uptake, we could see where the inequalities were. And so as we emerged from the pandemic and will not have those emergency powers, we felt the need to say to the system, we need to continue on the journey of making sure that we continue with that ethnicity coding. We said we needed to accelerate the preventative actions, particularly for communities that otherwise get left behind. And so we designed the Core 20+5 approach, which I'll talk about in a moment. And finally, we said we must strengthen leadership. Leadership and accountability. Without this strategic priority 5, the other 4 may as well not exist. Because without leadership, without accountability, we will be stuck in the old paradigms that I was talking about earlier on. And we didn't just stop there. We then said, we need to give people a framework to act. And so we looked at the Commonwealth Global Burden of Disease Survey. We looked at the data coming out of the COVID Disparities Report by Professor Kevin Fenton and many others. And we said, actually, the communities we need to focus on are the Core 20+. They are the 20% poorest. It's our ethnic minority communities. It's people with learning disability and autism. It's the people who are often voiceless because society either chooses to stifle their voice or ignore their voice. And so we said, if you don't know where to start, start with them. Start with the Core 20+ population group and drive relentlessly behind these clinical areas. We chose maternity because many of you have seen the Embrace report and what it has told us for years, that Black women and South Asian women are more likely to die in childbirth or the year following delivery compared to their white counterparts. We chose serious mental ill health because you know that Black young men in some institutions are 10 times more likely to be detained under the Mental Health Act than others. There was science behind the areas that we chose. For cancer, you look at bowel cancer screening uptake. You look at breast cancer screening uptake. You look at cervical cancer screening uptake. Again, the inequality in uptake. Science behind the framework. For children and young people, again, we said start with the Core 20+. But this time it was not a matter of premature mortality, it was about inequities in access. Because at the time, you take diabetes for example, continuous glucose monitoring devices available on the NHS, approved by NICE, but the data at the time showed that Black boys were less likely to be prescribed continuous glucose monitors. Question, why? Science behind the framework. And we didn't just describe a framework, we delivered an ecosystem for action. Because it's not enough to have a pretty infographic. The job is not done just because you published a policy or just because we published a framework. And it was important to build this ecosystem for delivery. And you'll see Core 20+ ambassadors there, and I'm sure I've seen Riyadh, there he is, where we mobilized a social movement. The Core 20+ ambassadors, professionals, of whom Riyadh is one, who genuinely care about this agenda, but don't just care, they have a track record of having done something about it in their local areas. Core 20+ connectors, lay people, trusted voices and faces in their communities. We brought them together to drive the agenda in a way that is much more powerful than Bola on her own, or one organization, NHS England, or indeed even the entire NHS. I share this to say that in driving change on a complex scale, you need a social movement. It is not a function of an individual or a solitary organization. You have to take people with you, and that's what this ecosystem is about. And these are the core 20 plus connectors. I think we're actually in wave 4 of them now. The other thing that we needed to do was to absolutely leverage the legislation and the policy. And so when the 2022 Health and Care Act was making its way through Parliament, we built a powerful coalition to say that the health inequalities duties must be more powerful than they've ever been. And if you haven't read it, I commend it to you, have a look. Because the next time you get pushback about doing the work in tackling health inequalities, you've got the legislation solidly behind you. It didn't just happen. Conversations with government lawyers and policy leaders to make sure that the law was as strong and as powerful as it could be. And beyond the legislation, what about the policy? With the help of the NHS Race and Health Observatory, the King's Fund, the Health Foundation, the Nuffield Trust, and so many others, making sure that the policy space was full of the evidence of the necessity for us to change. And it worked. Because you may have noticed that the current government published the eradication of the racial maternal mortality gap as one of their manifesto commitments. The social movement works. The government's mandate to the NHS contains a continuing requirement to address health inequalities. More recently, the 10-year health plan. I feel incredibly privileged to have been asked by the Secretary of State for Health and Social Care to chair one of the vision work streams of the 10-year health plan dedicated to health inequalities. The social movement works. And by leveraging policy and legislation, we can drive change regardless of organizational forms. Because whatever happens to organizational forms and structures, the mission remains the same. And this is the infrastructure that enables us to act. We worked with system partners, with the Race Equality Foundation, for example, to drive up the uptake of annual physical health checks for people with serious mental illness from a Black, African, and Caribbean community. Because we could see from the data that once again, our communities were not being represented in terms of the uptake. And this is what happened. Culturally appropriate ways of communicating with people, creating videos of people who look like me and you that people could trust and relate to. What else did we do? Making sure that actually the integrated care systems, as they developed their 5-year strategies and their joint forward plans, that they had a very clear story to tell about how they're going to address health inequalities affecting ethnic minority populations and the poorest in our society. What about sickle cell? For a long time, an orphan, but no longer. And this is what we have been able between us to do. And I'm very grateful to NICE, who looked at their criteria for assessing medications and therapeutics, and they did something to address the health inequalities gap. And as a result of that, we are the first country in Europe that has the gene editing therapy, ExaXL, available on the NHS for people with the worst types of sickle cell. People who turn up in A&E in sickle cell crisis, who would have been waiting for hours to get analgesia that should have been made possible within 30 minutes, no longer. We have this urgent and emergency care bypass pilots, making sure that people get access to specialist hematology intervention for their crisis. We launched the blood group genotyping program of work to make sure that when people have blood transfusions, they are less likely to have complications. For the people who want to donate their kidneys from a Black African background, we recognize that if you have the APOL1 gene, then you're likely to develop renal failure down the line. So now we test you for the APOL1 gene before taking your kidney. And if we find that you're at a higher risk, we follow you. Change is possible. And we ran the prescription savings campaign so that people living with sickle cell are aware about the existing mechanisms for reducing the burden of the prescribing cost for just living with the condition. We ran the Can You Tell It's Sickle Cell campaign, so that when you see someone in sickle cell crisis, you have the same level of urgency as you would for somebody who is experiencing a stroke, so that we can drive public awareness and professional awareness of what it is to be experiencing sickle cell crisis. The London group worked with Sickle Cell Society to develop Act Now, so that in the same way that when you see somebody having a stroke, everybody knows the FAST campaign, their face, their arm, their smile, time. Now you have Act Now for sickle cell. Change is possible. And we partnered, as they were called, with the academic health science networks, now the health innovation networks. And we said to them, NICE have approved most of the drugs relating to the clinical areas of Core 20+5. But if you look at the uptake, it's almost consistently lower in the ethnic minority communities who actually have higher the prevalence of the conditions. And so we launched the Innovation for Health Inequalities Improvement Program in partnership with the Accelerated Access Collaborative and others. And suddenly, in Greater Manchester, the uptake of inclisiran, which is a medication that lowers your cholesterol and reduces your stroke and heart attack risk, watch the numbers go up in the Black African and Caribbean population. Change is possible. And we worked with the National Institute of Health and Care Research to say, actually, we can leverage the power of research behind this agenda. My gratitude to Professor Lucy Chappell, who exhibited courageous leadership and decided to put significant funding behind each of the clinical areas of Core 20+5. And they launched in March last year with the first one, maternity. And this is looking, amongst other things, the impact of racism on women's outcomes. £50 million grant into maternal health inequalities research. And they're continuing across the other dimensions. How about what they've done? Now for NIHR, inclusion is a condition for research funding. Just imagine. Just imagine over the next 10 to 20 years, the material impact that this is going to have in the lives of individuals and whole communities. The answer lies between us. It's progress through partnership. What about the national audits? We have a whole swathe of national audits, diabetes audits, kidney audits, you name it. And we worked with HQIP, the organization that is responsible for these audits, to say, can we look again at these audits? Do we look through the lenses of ethnicity? Do we look through the lenses of deprivation? And they came with us on the journey, and they've made massive improvements in requiring that all audit programs must have an answer in terms of how ethnicity and deprivation will be accounted for. This is material, because the results of these audits drive policy, they drive research, they drive investment decisions, and this is why we had to partner with them. What about the libraries? So we've all talked about digital exclusion, and it wasn't enough to just publish a framework. We did publish a framework for digital inclusion, but we went one step further. We've partnered with libraries across the country so that they become places of sanctuary to give people access to digital healthcare. Because libraries, fortunately, are still around in many areas. So you can walk in to many of them, and rather than waiting to get an appointment with Dr. Bola, you walk into your local library, and we've partnered with many of them. Please give people digital access, particularly to their healthcare. We worked with the Care Quality Commission, the CQC, to look at the ratings and the inspections of ethnic minority-led GP practices. Have a look on Google, the report is there. And out of that came the Pioneer Regulator Fund, where they put funding into some of our poorest GP practices, laboring valiantly to help the people who are being left behind. And we had a conversation with our colleagues at the CQC in 2022 to say, but the ratings, I was at the receiving end of that. What can we do together? And out of that came this focused piece of work on how to inspect ethnic minority-led GP practices so that we can move away from the disparities in outcomes without compromising quality. And only 2 weeks ago, we've partnered with them to publish this framework to engage people and communities in a meaningful, respectful way to address health inequalities. What about Dame Professor Margaret Whitehead? Building on the really important work that the NHS Race and Health Observatory did to shine a light on the inequities in pulse oximetry during the pandemic. I was privileged to work with Dame Margaret Whitehead as she did this review and came up with this really important insights and recommendations. And I was speaking recently at one of the largest providers of healthcare products to the NHS and drawing their attention to what Dame Margaret Whitehead was saying about inequities at the design phase. We must be inclusive by design. Otherwise, we're going to leave people behind. But actually, it required influencing the policy to get to this point. What about the work that we did with the NHS Innovation Accelerator in partnership between us, NHS England, the RHO, and the NIA? And one of the winners of that award was the Sickle Cell Society, for good reason. Because sickle cell is an orphan no more. And beyond national boundaries, I have the privilege of sitting on the Global Health Equity Network Steering Group. The GEN is hosted by the World Economic Forum. And we were able to make the business case for tackling health inequalities. It's not simply a moral imperative. Many of you would think that this should sit with the World Health Organization. No, it sits in the World Economic Forum because we needed to make a business case so that business and industry who own enormous investments and resources can see the real contribution that they can make. It is about crafting the narrative in such a way that people who hold the purse strings feel compelled to act. And there's a whole range of tools and resources. I could only fit a few into this one slide, so that no one would say again, I don't know what to do, or I don't know where to start, or I don't have the tools and the resources. We are now awash with tools and resources. The question is, will we embrace our agency to act? 4 years on, this is where we've gotten to, and I could have shared much more with you. I think this is the power of recognizing our own individual agency, but also understanding the power of social movements, of partnering with others, understanding that you do not hold the answers as a lone actor. The humility of partnership, the courage of our conviction, the power of telling people's stories in a way that moves people to act. I remember when we were having the conversation about the gene editing therapy for sickle cell. I told the story of my 5 cousins who died of sickle cell. And that for me, this is a triumph. Nothing else that I achieve professionally will top this one. problem? No, we haven't. And I have my sights set now on AI and genomics. They are powerful tools, but don't forget the blind spot. Because the data upon which these powerful instruments are being built are for the most part European ancestry. And it's really important that we mobilize the power of our voices to say so. No one is saying we shouldn't make the progress. We must make the progress. But we must be inclusive by design. Have we fixed the problem? No, we've not. Prostate Cancer UK published this data about black men who have double the risk of prostate cancer compared to others. And I thank them and the NIHR for the Transform trial, the £47 million trial that they're currently running to prove the case that we need to think again about screening men at greater risk. We have the 10-year health plan. It will be published imminently. And I'm grateful for the opportunity to have helped in shaping it. We have a collective responsibility to make sure that its implementation works for those outside the bell curve. Everyone in this room has a voice. Embrace your own agency to act. And I'm very grateful to Jacob Land, who co-chaired this work stream with me, a powerful ally in this space. Find your allies. You can't travel alone. The answer lies between us. There is the men's health strategy. Contribute to the call for evidence. Say something. We cannot stand at the sidelines and complain if we refuse to use our voices when asked. Here is another opportunity. We will be publishing shortly the Community Languages and Translation Framework to make sure that nobody turns up for their hospital appointment or their GP appointment and doctors like me sit paralyzed by the language divide. It won't fix everything, but at least it will give us options to do something. Let me stop there. But I just wanted you to all understand that this is not the complex, impossible to do. This is the complex, eminently doable through the power of social movement, the courage of our conviction, and the power in our partnerships. Thank you.
Wow. If I could just say one quick thing, as someone who's covered health inequalities and workforce issues for 5 years at HSJ, I've heard from Bola many, many times, but there are very few times where I've been as moved as that. So thank you again, Bola, for your speech. So I just have a couple of things I need to announce, and then we'll be moving on to the next speaker. There is a prayer room on the 5th floor, the Hawking room, if anyone would like to use it. I've been told that I should make this, tell you obviously about this as we move on. And speaking of being inspired, there's something that I'd like to tell you as well. If you've been inspired by what you've experienced today and would like to support Khan's ongoing efforts or learn more about the impactful work, donation details will be displayed on the screen as it is right there. Your contribution, no matter the size, helps ensure these vital community initiatives can continue to thrive, and thank you for your consideration. So now we're going to move on to our next speaker, who's David Knott, who's the Chief Executive of the National Lottery Community Fund. If David could join us. Thank you.
Wow, thank you for having me here today to speak, and such a powerful and emotional call to action there, Professor Bowler. I'm here as an ally. I'm here as an ally and a partner on the social movement you're inspiring us on. Good afternoon, everyone. Thank you to Khan, to LDNinspire for bringing us back here again this year. Thank you also to my wonderful team at the National Lottery Community Fund, particularly Lillian standing up somewhere, and all of the National Lottery Community Fund team who've been driving action inside the fund and here today. Last year, I think it was a really important moment for us. It was a time for us to gather, reflect, hear where our voices and our agency lie. I hope today we're moving now into sharper, practical action. I hope when we come back together next year, we're talking about our accountability, our individual, collective, institutional accountability, what we're learning on that journey as we walk forward together. We didn't have the Secretary of State here this morning. I'm really pleased. Professor Bowler is at the heart of driving some of those changes in the NHS 10-year plan. I hope next year we'll hear from the Secretary of State explaining his accountability for putting health inequality at the heart of whatever these new structures and 10-year plan will focus on. Look, thank you for allowing me to be part of this conversation. Look, let me also start by saying I will not experience the realities and the experiences many of you have day to day, but I am here as your ally and as your partner to work alongside, to understand the changes that we need to make together. It was a passionate discussion last year. It left a deep impression on me. It's an emotional spur for us all to act in our own ways. It left a deep impression on me and our whole team at the National Lottery Community Fund. We were left inspired, a stronger sense of shared purpose. I'm here today to say some of the journey that we're on, some of the lessons that we've learned. We've not figured it out. It's a journey we're on, and a journey I hope we're walking on together. We're a room full of energy, of passion, of creativity, of desire to act. That brings change. That's the social incubator for change that we want to do together, and will be more when we combine the strengths, the powers that we all bring to make communities that are healthier, more inclusive, more fair, where everyone has that chance to thrive. We're talking about many stories today. I'll give you a story of where I live in Lambeth, and Lambeth's a thriving area. It's bustling with culture, it's bustling with history. And a few years ago, a group of residents came together with a shared vision to tackle the challenges that they felt were holding the community back. They weren't small challenges. They were deeply rooted. Issues like mental health, unstable housing, barriers to good jobs. What stood out, though, was the belief that real change could happen and couldn't be imposed from outside. It needed to be led by the community. It starts with community. They knew their community best. They had the insights to drive solutions. And out of that determination, a partnership was born. His mission was tackling those systemic barriers that were impacting the mental health and well-being of black residents. Black Thrive Global was supported with £5 million from us at the National Lottery to extend, deepen their work. They created a platform where black residents, grassroots organisations, service providers could work together to design solutions that fit their community. It's really transformative work. A big focus has been on employment, an area where we just know those systemic biases have shut out so many members of the community. But it wasn't focused on traditional job placement programs, they took a different route. They started with those conversations with employers, with the community, identifying the barriers, building more equitable hiring practice. And that changed the conversation. It opened doors to more meaningful long-term employment that hadn't existed before. Of course, with social movements, they didn't stop there. Moved on to housing, to healthcare, making sure everything that they did was centred around the voices who had been most impacted. And that's got into a bigger movement, a movement that empowered individuals, built trust, and shown what's possible when a community takes the lead in driving change. Because that story really, for me, gets to the heart of what we're about at the National Lottery Community Fund. We believe real change begins with community. We say it starts with community because it does start with community, grounded in trust and supporting those closest to the issues. Because we know that truth, don't we? That those who are affected most by poverty, inequality, discrimination, are the ones with the most energy, the innovation, the ideas for change. And our role, I believe, at the Community Fund is to stand alongside and with them, providing the tools, providing the resources they need to shape futures. Not just today, not just tomorrow, for the very long term. We talked about agency, power, unlocking control. These are really, really powerful terms. So one of the areas where systemic injustice is really most visible, and we're focusing on today, is health. And we all know how stark those inequalities are. Lots of statistics we've heard. And they don't exist in isolation. They're linked to poverty, housing instability, lack of access to opportunities. They're structural. We keep using that word, it's important. They're not individual failings, and addressing them requires us all to be bold in challenging the systems and structures that allow them to persist. So one of our real focuses at the National Lottery Community Fund is evolving how we partner with communities to tackle these issues. And we're currently redesigning 2 of our funding programmes, our Reaching Communities and Awards for All, to make sure they're more focused, more accessible, more aligned with the peoples that we serve. And we're doing this with input from communities to make sure we get it right. And actually, if anybody was there this morning at the workshop my colleagues were running, will have heard some of the ideas. We're asking for help and advice as we look to change. And if you weren't there this morning, please come this afternoon. We're running the same session again. Because our goal is to ensure that funding reaches those who need it most and supports the solutions that address the root causes of inequality. Let me give another example of what that looks like in action. We're supporting the Jasmine Recovery Programme. It helps South Asian women who've survived domestic abuse and violence. We've supported that work through our Reaching Communities work. It's a transformative programme that they're running. It stands as a real beacon of hope and support for women who've endured domestic abuse and sexual violence. We know women there are facing quite unique, compounded challenges. Cultural stigmas, the language barriers, the societal expectations that can make it hard to access the support they really need. And the Jasmine programme is trying to break down those barriers, meeting the emotional, physical, social, practical needs of those it serves. Central to that work is creating the safe, nurturing spaces where survivors of domestic abuse and violence can feel secure, supported, and free from judgment. They're working really tirelessly to ensure services are culturally sensitive to diverse traditions, values, and language. They're creating inclusive spaces where women can feel understood and respected. And that work is really helping to break cycles of violence and fostering healthier families and communities. So these are great examples. But what I want to say today is we want to work faster, go further, and look at the systemic issues and systemic funding that is required behind these. So coming back this year, I'm really delighted to be able to commit now £50 million of our funding each year. That's 10% of our National Lottery funding to our Solidarity Fund. And solidarity is such an important word here. That's going to be committed to really long-term funding, core funding to organisations tackling root causes of poverty, discrimination, disadvantage in our communities. We're designing that with equity at its core, looking to address the biggest barriers that people identify to access to opportunity. And again, please come this afternoon to our workshop to help us in our thinking and design behind these programmes. But it's more than funding, it's also about sharing decision-making power, creating really lasting partnerships. So we're going to be inviting communities to take the lead, using lived experience to shape this strategy. So again, please just join us this afternoon at our workshop. We're trying to co-develop this approach to tackling health inequalities that are deeply rooted in racism and discrimination. And that's our commitment on health equity. It's one of our focus areas in It Starts With Community strategy. And in that, we recognise those larger forces, the social forces, the institutions, the ideologies, the processes that are interacting with each other to generate and reinforce inequality that we've seen it too long. And these social factors at play in health, the conditions in which people are born, live, work, grow, and age, income inequality, the unequal access to health and social care, education, stigma, racism, all of these underlying contributing factors of health inequity. So we want to hear from everyone in this room. We want to work with you as equal partners. Your insights, your experiences are really critical in shaping what comes next for us at the National Lottery Community Fund. We also know funding is only one part of the puzzle. Trust is just as important. We want communities, all communities, I often think, as a national institution, to whom do you owe power? To whom do you serve on a day-to-day basis as you exercise the power and privilege that comes with who you are as a national institution? And we want people to see us as an institution, the National Lottery Community Fund, as a reliable partner, a partner that's ready to listen, to work, to learn, to adjust. We're looking inward too, ourselves as an organisation. And we want to hold ourselves to account to how we'll embed equity in everything that we do. So later this spring, we'll also, alongside some of those funding measures I've announced, like the Solidarity Fund, we'll be saying, what does equity-based funding mean for us across all of our national lottery funding? And alongside that, our commitments on us as an organisation, what we will be doing on our representation, our recruitment, our transparency and accountability in data and understanding as we work forward. We'll be looking at our funding practices and how we make sure our funding is open, accessible, speedy, and gets to the grassroots organisations that need it most. So, look, trust is built by action, not by words, isn't it? It's about showing up, it's about being transparent, it's about sharing power. We hope we're at the start of creating those lasting partnerships that empower communities to drive change they want to see. So mindful of time, I stand with you today. I feel humbled, I feel hopeful. Hope's an important word, isn't it, for us? Humbled, my own experience is just one, it's limited. Together, our perspectives, our insights can unlock that greater change, that social movement that Professor Bowler spoke about so eloquently. Humbled because I can learn so much from everyone in this room, and all of us at the National Lottery Community Fund can and we want to do that. But hopeful because I see that passion here again this year, that knowledge, the strength that we have inside this room. And as we've heard, that work is hard, isn't it? It's systemic, it's quite deeply entrenched. It's not going to change overnight. But I do personally believe that by centering people and communities, by bringing their voice, building that trust, working collaboratively, we can create a future that's more fair, more just. It's a journey we must walk all together. But look, at the National Lottery Community Fund, I think those 4 words that we say, we truly believe it does start with community. And I think more community, stronger community, working together as a community must be the answer to some of the big social challenges that we see and are working on. Thank you for sharing the space. I look forward to more of that this afternoon.
Thank you so much for that. And thank you, Bola. I think everybody was just like, it's so heartbreaking to hear what you've been through with your family. But thank you for sharing that with us and for the amazing work you're doing to help people. So please give a round of applause to Bola. So up next, we have Professor Habib Naqvi, who's coming up on the stage. He's going to be talking about, first of all, actually, he's the Chief Executive of the NHS Race and Health Observatory, where he leads groundbreaking work identifying and addressing systemic racial inequalities affecting patient communities. So give a round of applause for the great doctor.
Thank you so much. Thank you, Khan and Inspire London, for another fantastic event. And it's great to be here today amongst friends and familiar faces, particularly during a time of uncertainty for many people working in the NHS at the moment, and particularly during a time when the NHS itself is facing and experiencing unprecedented challenge. And that challenge exists with regards to the unacceptable long waiting lists that we have in the NHS at the moment, with regards to the thousands of vacancies on the front line, with regards to the impact that COVID-19 pandemic is still having on our communities, on our patients, and of course on our health and care staff as well. And alongside the joys and the positivity of increased life expectancy for populations, there's also the challenge of long-standing inequalities in health, long-term conditions that come along with that good optimism as well. And of course, what our work has shown at the Race and Health Observatory time and time again is that those challenges are inadvertently experienced by Black, Asian, and ethnic minority people. And in fact, next week on Tuesday will be exactly 4 years to the day that the Race and Health Observatory was established, just before the pandemic actually broke out. And I give my thanks to Lord Simon Stevens, Victor Adebowale, Bola, for guiding us and establishing an organisation that really focuses on what Victor calls the causes of the inequalities that we see. An organisation that holds up a mirror to the rest of the healthcare system, including, I have to say, NHS England itself, but in a positive way, that we can actually make change happen. And one of the first things that we did at the observatory to make that change happen was to carry out a rapid, systematic review of the state of play with regards to ethnic inequalities in health, and to begin to use the word racism in healthcare. And that systematic review did make the front pages of the newspapers. And I always highlight this slide because this was perhaps one of the first times that racism was talked about in a very public way, about an institution that we hold so close to our hearts, about the NHS. And what we did on the back of this was to think about what is it that we really want to focus on in the next 3 years ahead. And we thought about, what does racism actually mean? And we developed a model. We brought together different parts of existing models to really tell a story of how racism plays out in a way that impacts people's lives, whether you're staff working in the NHS or your patients and the community that we're here to serve. And that is the structural racism that we have within society, how education, the criminal justice system is impacted, or how it impacts ethnic minorities in a different way. It is the interpersonal racism that we experience on a day-to-day basis. And people often call it, use the term microaggressions. I don't like the word microaggressions because I don't think any aggression is micro. I call it macroaggressions. And how those two forces, the structural racism and the interpersonal racism, play in and play out with regards to our institutions, and institutional racism, and how that plays out in the policies and the processes that we often experience or use on a day-to-day basis. And over the 4 years, we've done a number of pieces of work. This is just a flavour of the work that we've done over that period, and Bola's talked about some of this as well. I think the slides are working very fast, so I'm just going to go back to some of the work that we have done. Pulse oximetry is there on the top line, and I use that as an example because that really helped us think about our operating model within the observatory, which is based upon what we call the 3 legs of our stool. Bring together the evidence base where it exists, or to establish it where it doesn't exist. Turn that evidence into policy recommendations for change. And then thirdly, support organizations to implement those policies on the ground. And in fact, with that work, at the heart of a pandemic that was obviously affecting the levels of oxygen in people's bodies, we knew that there was an evidence base, particularly from the US. The darker the color of your skin, the less accurate these devices are likely to be. We turned that into policy recommendations. In fact, there were only 4 recommendations in that report. One for the MHRA, the devices regulator, one for NHS England, one for the NIHR, and one for the Department of Health and Social Care. And we supported those organizations, worked in collaboration with Bola to make sure that those recommendations did not just sit on a shelf gathering dust, but were actually acted upon. And on the back of that report, the government announced an independent review into medical devices, which Dame Margaret Whitehead led. NHS England updated their guidance on the NHS Choices website fairly quickly, particularly in relation to home pulse oximeters. NIHR put out a substantial call for further evidence. So that's how we can use that operating model to make change happen. Emergency situation, we needed to act pretty fast, and we needed to show our independence as an organization, but also, as Bola says, our partnership working with other organizations to impact change. And these are some of the impacts that we have made to date. Neonatal testing on the back of our neonatal testing report, and Janet's here in the audience, and many others, Faye as well from Khan, who have supported us along the journey. On the back of that report, NHS England rolled out mannequins and birthing simulators in different skin tones across every maternity unit in the country, the first time in the history of the NHS that has been done. So thank you to NHS England and Bola for your support on that. Medical devices, I've already mentioned. NIHR, Bola's mentioned in terms of adding equity as a core criteria for funding. In fact, we've got a MOU with the NIHR, and that's to support the NIHR to make sure that we have a focus on research that looks at ethnic inequalities. But not just that, but we also have a focus on diversifying the people that actually lead the research as well, which is critical if we are to have that diversity of thought and understanding in the work that is carried out. Sickle cell disease, learning disabilities, and the work we did with NHS England, looking at some of the stark inequalities in life expectancy for sickle cell. And some of the other work on the right-hand side, including, of course, COVID-19. I was on a call this morning, actually, with the University of Leicester, looking at the continued impact of long COVID on our healthcare workforce, a report that we'll be launching in the summer later this year. And, of course, we also focused on anti-racism principles, using the knowledge base that we have and the expertise we have on our board and our partnership with other organizations to focus on what is it that organizations can do. Because when we speak with leaders, when we speak with organizations and integrated care systems, we often hear leaders say that actually, yes, we know that there's a problem around race in my organization or my system, but I don't know what to do. And we thought, that these principles, which are evidence-based, will help. There are 7 principles. I won't go into them in too much depth, but just to highlight the fact that there needs to be an understanding, knowledge base, data. There needs to be the use of data. Turning data, as Bola says, turning data into insight and insight into action is really critical if we are to shift the dial of inequality. Meaningfully engaging with communities, something that the NHS perhaps hasn't done so well over the decades. Engaging with communities in a meaningful and sustained way, not just with regards to a specific intervention, but looking at how that engagement needs to continue beyond that. That's one thing that we've been embedding within the development of the 10-year plan. Yes, there is now an increasing level of engagement with diverse communities and staff. That needs to increase as we go forward, but that doesn't need to stop when the plan is published. We need engagement that continues way beyond that with regards to the implementation of the plan as well. But I think the most important point around those 7 is the first principle, identifying and naming racism. Because in any sphere of life, if you want to change something, you have to acknowledge that there's something there to change. And if you do not acknowledge and recognize that racism exists, then we will not be able to move from that first step into the subsequent steps. We will not be able to have that shift in the dial of inequality that we want to see. And the observatory isn't just about outlining the scale of the challenge, but coming up with practical tools for change. I mentioned the neonatal report on the left-hand side. And on the back of that report, in collaboration with Medway NHS Foundation Trust, and I think there are 2 colleagues in the audience, Helen and Ruby, that were instrumental in producing this infographic on the right-hand side, a very simple infographic. 10 steps to spot jaundice in black and brown babies. It's what you can do with the data and the insight that we already have. We know of the challenges. We already have lots of data. It's about turning that into practical support for organizations. And that infographic on the right-hand side now becomes an excuse remover. There cannot be any excuses for people, organizations, or the NHS to say, actually, we don't know what to do, or we don't know what to spot. So that's the kind of work that we need to do as we move forward, not to highlight the issues or to think about what the data is telling us, but to actually turn that into practical action. Next week, we'll be publishing our strategy for the next 2 years, for the next 2-year period. And that strategy includes six or seven principles, fundamental kind of principles that I've outlined in the next two slides, this slide and the next slide. And you'll notice that these principles are grouped under the three shifts that the government is talking about: the shift from hospital to community, from analog to digital, and to prevention. And within that strategy, we will continue to focus on some of the long-standing, deep-seated inequalities that exist for our diverse communities: maternal, neonatal care, looking at mental health, particularly as we move forward to the revision of the Mental Health Act, to looking at education and cultural safety, looking at research and evidence, how we can diversify research and diversify education as well. What gets taught, what doesn't get taught, what features in our textbooks, what doesn't feature in those textbooks. When we did the work on pulse oximetry, we had a large number of doctors that came up to us and said, actually, we weren't taught any of this in our undergrad, postgrad, or CPD courses. So it's important that we diversify education. Technology and innovation, the work around sickle cell and digital care pathways continues. The work around genomics, the work we're doing, in fact, which Dr. Valine Lesperance, who's in the audience, is leading on and has a stand downstairs around genomics, is critical to the work we do. And that includes the work we're doing with organizations like the University of Liverpool that are looking at an anti-cancer drug that doesn't get broken down as quickly in black bodies as it does in white bodies, has led to higher levels of toxicity. Why? Well, because the genome sequencing misses the African variant in the development of that drug. So how can it meet the diverse needs of our diverse communities? So this is about looking at some of the causes of the inequalities that we see as we move forward. And number 7, I'll just kind of highlight this one, because if we're in the business of tackling these inequalities in health, which we are, then we need a workforce that's fully supported and fully engaged and fully represented at all levels, including at leadership level. And we know that's not the case, and historically has not been the case in the NHS right from the outset in 1948. So we'll be looking at the ethnicity pay gap review as part of our strategy. And in fact, not just the pay gap, but also the pay and progression gap within the NHS, what some people call glass ceilings, but I call sticky floors, where people stay in certain grades for not just years, but for decades. And I've talked to those people on a regular basis. We'll also be looking at bullying and harassment with regards to the NHS workplace, closing the ethnicity gap in terms of bullying and harassment, but also reducing overall levels of bullying and harassment for all staff as well. And my final slide is about inclusive leadership, because this whole agenda is about inclusive leadership. It's about understanding why we do what we do. A couple of weeks ago, we published a report called The Cost of Racism to the NHS. Have a look at it on our website if you haven't seen it. It's about highlighting not just the moral case and the legal case, of course, which we have, but also the financial case to the NHS of not focusing on this agenda. So it's about closing the gap between the promise of our ideals, which are, in fact, in the Constitution, and the reality of our time. And that reality does include the stark inequalities in health that we see, the stark inequalities in healthcare and the workforce that we see. So I remain optimistic as we go through a period of change and reform for the healthcare system, because this is an opportunity for us now to embed and hardwire this agenda for the future of the NHS and for our future generations to come. Thank you.
Thank you very much, Habib. It's quite interesting listening to both Bola and Habib because they have a way of demonstrating how this isn't just an optional thing, it's mandatory. And I can see from the people who have attended this summit, it's clearly something that resonates with a lot of us. So moving on, we now have the afternoon workshops, which should be displayed on this screen shortly. They are starting now, so if you could please make your way to the afternoon workshops that you have subscribed to as they are up there. You don't have to stop in the main room downstairs to get teas and coffees. They are in the rooms themselves, but you should be able to find them there. I can't hear you. Thank you very much. The workshops are for 30 minutes, so please come back within 30 minutes for the next portion of the summit at 3:30.
If you're not staying for the AI workshop, can I ask you to move on, please? Can I ask you to move to your workshop so we can start the... Bola's fan club has gathered. Sit down with you, and I'm going to ask I've got your details. I know it could be months away because you're so busy.
No, it won't be months away. Let's not make it months.
All right. Thank you. No, not me. Thank you. My God.
Bringing us together.
So powerful. So powerful.
Thank you. So let's have lunch.
You got it. We'll do. Okay, we'd like to start the AI workshop in here. Just saying. Just say, I mean, you know. David Knott is now the most popular man in the room. 50 million. Okay, can we move on, please? Mr. Knott, would you mind take your fan club with you? Oh my God. Oh my, a selfie. Cash. he says 50 million, all of a sudden people are like, oh. Marsha. Okay. We'd like to start the workshop. If you're not taking part in the digital workshop, can I politely implore you to leave? Well, we just lost 6 minutes. Okay, let's make a start. Thank you for joining us for this afternoon's workshop. It's a slightly abridged version because we're now up against it time-wise. It's unlikely that we'll be able to take more than 1 or 2 questions, but we'll try our very, very best. But it's really important that the speakers be allowed to go through their presentations. I think we'll get a lot out of that. And can I just make you aware that already people are lobbying for a full one-day conference on AI and digital. So hopefully we'll get that in the autumn. It's really important. For those of you who don't know me, I'm Sedi Frederick, and I co-chair Inspire. I also chair NHS Kent and Medway and lots of other things as well. And one of the things that I've been involved in for about 4 years now is what I've described as my passion project, which is Conciliaris Digital System. You'll hear from our speakers, Ed, Ruchi and Marianne, and hopefully if we have time, we'll have questions before we get asked to close down and move on and so on and so forth. So let's get started. Ruchi, you're going to be leading us off. Hopefully the technology will be kind.
Okay, this is going to work. Yes. Hi everyone, I'm Ruchi Singh. I work a lot with SEDI in that transformation space, so working across the NHS and wider government to deliver practical, pragmatic change. So today we're going to take you through a little journey about AI and the art of the possible, and looking at actually the real opportunity it provides, with some caution about really affecting the health inequalities in the system, which is what we're talking a lot about today. So there'll be 4 parts to this conversation. I will start talking about the macro environment around AI and why you should care. I'll hand over to Dr. Marianne, who will talk about some interesting use cases, and then I'll hand over to Ed, who will show some of the really amazing tech, which is culturally inclusive around that is based on AI. So I'm just going to carry on. Before I start, by a show of hands, who is well versed in AI in the clinical space? Who uses AI like ChatGPT or Claude on a regular basis? Who doesn't use it at all, doesn't care, or is curious about it? Okay, good. I know who I'm talking to now. Okay. Okay, so we're not going to do the Mentimeter. So I talked about that. So what I'm going to just talk about is why AI matters. So we are at another trigger point in our world where the pace of change is changing again. It's no different to when computers were introduced in the 60s and 70s, when the internet was the next big thing in the 80s and 90s, and now we're at AI. And I know it's quite an overwhelming space. You think, well, it's all happening over there. It's going to take over our jobs. We're going to be irrelevant. But actually, it does matter. And there is a point to it. and more so now because we have yet another round of cuts that are coming our way. NHS England is about to go. ICBs are being asked to deliver 50% cuts. I had a conversation with the CEO yesterday, and he was telling me, I'm getting rid of one of my operating theatres and I'm closing a ward. And that, for me, it just doesn't compute. We've got unprecedented waiting lists right now. Why are we cutting supply when there's huge demand? And this is where I think AI really matters, because we can either retreat to what we've always done, which is get down into those cuts, cut more services, reduce our headcount to deliver those budget changes, or we can really lean into what might feel like a bit of a scary place. And I was saying to Opus earlier that actually it feels a bit like a roller coaster, but like all roller coasters, scary to get on, but man, was it an exhilarating ride. So that is the opportunity to reimagine what your service could be, how you support your communities, how you can really deliver that service, that quality impact that you want, which you wouldn't normally have, especially in a system full of cuts. So I know some of you had put your hand up that they're looking at some clinical areas, but AI also can help the system element. So how you deliver customer support, how you deliver automation of appointments. There's lots of use cases that, if you had the confidence as leaders to think about, you could absolutely get through the cuts and actually come out reasonably well off. I'm very cautious with my words because it still costs money to get them into the place, but I think what we really need is some leaders with courage and leaders with curiosity to really take advantage of what's out there. There's lots of providers who've found that niche, but you just need to understand how to do it. So that goes on to my next point, which is proceed with caution. So don't chuck the baby out with the bathwater. There's lots of industries using AI, and there's no reason why we can't use AI in the health system. Yes, we need to understand patient privacy, patient safety, patient respect, but absolutely AI can really lean into the diversity, be more diverse and more inclusive. Yes, there are a lot of clinical apps out there, like some of the dermatological ones, which don't recognize brown skin, but when we know that, we can absolutely work with those organizations to make sure they get the right data set. So I'm going to hand over it. So bearing that in mind, I think there's a question for you, is when are you going to start? And I think starting now is the only option we have, because it's moving at a rate of knots. AI is changing every week. Now, every day, I should say. So I'm going to show you something that Conciliaris have created, which is about that culturally inclusive application, just to give you a little bit of a taster before I pass on to Marianne. Is it going to work? No?
Hello, I am one of CU's AI Health assistants and companions.
Hi, I am Samantha, one of CU's AI Health assistants and companions. How can I help you today?
Hello, welcome to a new era in healthcare, where AI avatars like myself are available to offer assistance with your health needs.
Hopefully that tickles your curiosity, and now I'll hand over to Marianne.
Good afternoon. Hi, I'm Mary-Ann Froh. I'm the Chief Medical Officer at Health Innovation, Kent, Surrey and Sussex. For those that don't know about the Health Innovation Networks, there are 15 of us across the country, and essentially we find, test and scale innovation into health and social care. So I thought I'd just give a little bit of a flavour around AI. We don't have a huge amount of time, but some basics around what it is, some community insights and a case study, and then if we have some time, perhaps a bit of a discussion and some questions. But essentially, AI, what is it? That's what a lot of people are asking. I like this definition. So thinking about it, referring to computer systems, software designed to perform tasks that would usually require a human being. So tasks that really learn from data and can include things around decision making, problem solving, recognizing patterns and speech. But AI actually incorporates quite a number of different things. It's kind of a very broad term, but actually these are the four main things that fit under artificial intelligence. So we've got kind of robotic process automation, we've got algorithms. You might know, you've got an algorithm in your social media, in your TikTok, in your Instagram. That's what that's talking about. Machine learning, so using big data sets to learn sort of pattern recognition. There's a lot happening in that space around pathology, radiology, dermatology, around diagnostics. And then you've got this sort of natural language processing. So that's the ChatGPT, that's your virtual AI assistants, that's your chatbots. So we know that AI is here. A number of you have put your hands up to say that you're already using it. So how is it being incorporated into health? And what we're finding is actually some places are already quite far ahead in their journey, and some places haven't even thought about the concept of incorporating AI. But as I mentioned before, it is starting in some key areas around diagnostics, and in particular around cancer, and that's our predictive AI. And there are companies like Skin Analytics looking at diagnosing skin cancer. We've got operational AI that's already being deployed in various different acute trusts for patient flow management and improving demand. Expert systems, so that's kind of clinical decision support. We've got that happening in primary care around e-triage systems, etc. And then we've got this generative AI that has rapidly taken off, and that incorporates things like ambient speech. So we've got clinicians having the AI on, it records the entire consultation and puts all of that information directly into the medical record. It's done a summary, it's done your letter, it's done your referrals, and it's done whatever blood tests that you might want to order as well. So things are moving at pace, and how do we start to think about how we can incorporate that within the NHS? And these are sort of some key things that we will need to think about as we move on this journey. So the fairness and inclusion. So we talked about data being really important, but we know a lot of the data is actually taken from research and clinical trials. Well, who are the types of people that were included in that research? They're often the demographic of white male and of a particular age. And we know that women and those from ethnic minority groups are not within those data sets. So if we're designing and developing AI off that data, we are building in and baking in racial and gender bias. So we need to think about that. Accountability and recognition. So we don't have the strength of legislation and policies in place to manage what's happening because it's going at such a rapid pace. You might see kind of in the newspapers, it talks about Facebook and ChatGPT and talking about how do we go about the governance of AI. And that's still in conversation. It isn't actually in place. So again, how do we mitigate some of those risks? And the final part is around the transparency and explaining it to people. So if you're using that ambient AI, does the patient know and understand what types of tools that you're using to enhance that consultation, and how much information do they need to know to adequately give informed consent? So we did some community insights with a wonderful person called Sylvia Stevenson around what did women really think about AI, and could we start to think about engaging communities in co-design. And so we had this wonderful group of 32 women in the community who are from Black, African and Caribbean backgrounds, broad range over 4 generations, and really started to delve into some of the questions around how they felt about AI. And this is what they said. So they said there was really this element around education awareness. What is the information that's available for people who want to learn more about AI and making it accessible and easy to understand? Inclusive representation, so ensuring that those people from minority backgrounds are actually included and participating in the design phase of AI and within research. That there's cultural competency and cultural safety at the heart of what we do. So, and that's both with the design and development teams, but also from the clinicians who might be using that technology as well. And then finally, really starting to think about trust and how we bridge that gap, and how we ensure that everything that we do is inclusive. And this is a bit of a case study, so I thought I'd just pick out someone who's kind of doing it right and has got a really good approach. So this was the Tommy's app, and it was an app to address that key part in the middle, which was the maternal death rate for black women, which is 4 times higher than for white women. And what they really wanted to do was develop a digital app that improved maternity care, that was much more personalised, much more holistic, but also addressed the key element of gender and racial bias within their algorithm. And so what they did was they took a co-design approach. So they actually got the women's voices at the table to really understand what their needs were and ensure that it was culturally sensitive. They got experts from around the room, both from midwifery and obstetrics. They used an evidence-based model of care, so not just picking something because it sounds great, but really ensuring that there was some robust methodology that sat behind it. And then putting in this AI risk assessment, so understanding that there might not be things we can always prevent, but we need to mitigate, but we also need to assess it. So putting in some risk assessment. Education and training was critical. So don't assume everyone in the NHS has digital skills. In fact, 1 in 8 people have very poor digital skills in the NHS, to the point of some people not knowing how to use the internet, like that poor. So we need to make sure that, you know, that's incorporated in both the digital literacy and skills of patients as well as the staff that are being asked to use these tools, and then having a process for monitoring and evaluation and making sure that we're actually measuring the right things. So not just bean counting of what X number of people downloaded this app, what actually was their experience and did it enhance their outcomes. And that's it for me, and I'm going to hand over to Ed, who's going to show you what the future could look like in terms of AI and avatars.
So, Ahmed, the techie in the room, so forgive me. And techies don't like speaking, but I'll try to do my best. So I'm the co-founder along with Seti, and long title just for somebody that codes stuff and designs stuff. But look, the reality is AI has arrived, right? Whether we like it or not, it's here. And what we've decided to do, and I guess we're pioneering in the space, is we decided to be very inclusive early on. Tech. There we go. In our approach to the solutions that we create. I'm going to take you through a couple of scenarios. Essentially what you're looking at is one of our engagement apps that uses a very sophisticated AI companion. I'm not going to call it assistant, it's a companion that is the gateway for a patient or somebody that needs some sort of medical advice at the time. In this case, one of the scenarios was, I woke up with sudden pain on my left arm. What does it mean?
I'm sorry to hear that you're experiencing sharp pain in your left arm. Could you please tell me if you are also experiencing any other symptoms like chest pain, shortness of breath, or dizziness?
So one of the things that's prompted us to design this kind of interface is if we think about the moment somebody experiences that pain, first thing they think about is call 999, call an ambulance, speak to a
Do you have any other symptoms like chest pain, dizziness, or nausea?
And it stresses them out. I know I get stressed. So speaking to an...
I'm sorry, I didn't understand your response.
Yeah, okay.
Could you please clarify if you are experiencing any chest pain or dizziness along with the sharp pain in your left arm?
So speaking to an AI assistant very early at the condition point, I think helps in two ways. One is just alleviate the stress of the patient, potential patient, but also educate them in the right and immediate pathway to take.
Based on your symptoms of sharp pain in your left arm and feeling a little short of breath, it's important to consider seeking immediate medical attention as these could be signs of a heart-related issue. I recommend you call emergency services or go to the nearest emergency room for a thorough evaluation and appropriate treatment. It's better to be cautious with symptoms like these.
So this is an example of how we've taken the concept of AI and pushed it a little bit further. A lot of the coding stuff that we've done is very much focused on us, people like us, real people, not just from a diversity perspective and a culturally accurate perspective, but also thinking about how it responds to questions along its use life cycle. And I think that approach helps build trust in a system that's effectively broken, to be honest. And with I guess, scaremongering about AI getting things wrong, not responding accurately, etc., it just exacerbates that problem, and the system continues to be broken. So with the work that we're doing at Conciliaris, we're trying to not just fix the system, but change the interaction. AI is here. It's going to be helpful, but it should be helpful and meaningful as you use it. And one of the things that we've done is create a series of tools, not just the AI assistant, but culturally accurate and sensitive avatars that can pass on messages that we need to hear at the time that we need to hear. The next one, is it? This is an example.
I'm sorry to hear that you're experiencing a headache.
Of another AI.
Let me help you assess the situation so we can determine the best course of action. Could you please let me know? How severe is the headache on a scale of mild to severe? Are you experiencing any other symptoms such as nausea, sensitivity to light, or visual disturbances? Do you have any difficulty breathing or a persistent cough? Your answers to these questions will help me better understand your condition.
So these AIs that we've created are not just kind of plucked out of my coding head. Our chief medical officer is actually the inspiration for our actual AI companion on the app. And she's sitting there as Dr. Opus. Real person with real mannerisms and all thrown into digital tech. So basically, I've tried to take her personality and apply it to tech and move that across. And on this one, all I did was create another fake person and do some magic, and the way it is, it's done. But the key thing is, tech is here to help us, and we believe that tech needs to be applied for good. And AI, we're at a juncture where it's coming fast. I've been doing this for way too long. My first true AI transformation program was back in 2012, right before you even heard about what you're hearing today. So it's been around for a long time. And we always knew that problems would occur because the data that we had back then was wrong. fast forward 10, 20 years on top, but the data is still wrong. If we don't accept and embrace the tools now, we can't feed the correct data to those tools. So our view and our perspective at this juncture is, let's embrace the tools, ask the right questions, use them as much as we can so we build the correct data set, specifically for people like us, right? It's very, very difficult to train an AI. I know in the morning session we were asked about blinking. I forgot this one blinks. But one of the most difficult things is building a culturally sensitive digital mechanism to represent a person when the underlying code is based on a completely different type of person. It's very, very hard. So, and we don't have the data readily available, so I can just go click that, get that resource, compile it. And I think we're at the point specifically around healthcare as it's the source of all the data. If you want to know about a person, healthcare is that's your door, that's your entry point. So if we can start collecting that data and applying that data correctly and just changing how we use the tools, you know, we can create apps, interfaces.
It's a powerful healthcare application. It provides users the ability to access healthcare services at any time in any of the main languages.
A patient set up in CU will have access to all their important medical and vital statistics only visible to them through our secure app. Once the patient record has been created, they will be able to see a 3D avatar that resembles them. Interacting with it is as easy as pointing to the part of your body where you are experiencing an issue. Then it is just a case of answering the questions on screen until the triage is completed. The AI will prompt and guide you all the way and even check your GP's availability so that it can provide options for appointments that you choose. Our intelligent booking system helps to reduce and eventually eliminate those costly no-shows.
And this is one of the application scenarios, is putting technology at the hands of users in a way that they want to use it. And one of the biggest problems we have is calling and trying to book an appointment. I go through that with my daughter, and it's a pain. It hasn't changed. And I firmly believe, I'm biased but I think we have an opportunity to change how you access healthcare services with the support of AI systems. But those systems need to also be culturally relevant to who is using them. And that's what we've done with CU and our health platform. What you've seen here is just a fraction. It's actually, it auto-translates, the avatars change to the language that you're changing, etc. We would have been here all day, basically. But generally, that's one of the scenarios of applying AI. And in healthcare, we have this opportunity to fix a problem that we know is a problem. And Dr. Obola mentioned that, you know, we keep banging on the same door and nothing actually gets done. Now's the time to do it. You know, we have the tech, so let's do it. Thank you.
Thank you, Ed, Ruchi, Marianne, and thanks, Opus, for being our wonderful, well, Chief Medical Officer, but also our avatar. Thank you very much indeed. I am conscious of time, but just to contextualize this from my point of view. So Ed and I started on this journey in what, 2021? 2020. Apologies, 2020. It's been a long journey to this point. All of what you've seen has been funded from my pocket and from Ed's pocket. So if you know any rich people who want to invest and help us take this forward, let us know. Very, very quickly, limited time. Any questions for the panel? We have rushed it. There's a couple back there. So Sam's going to bring until we get told to stop, I'm going to take questions.
I'll tell you.
Yeah, but I'm the co-chair, though, so, you know. And if you don't listen to me, Juliet will tell you.
Yes, very interesting talk. How far are you from, currently you've got audio and touch interaction. How far are you from audio to audio interaction?
Ed?
It's already there.
It is?
Yeah.
Hi, I'm all behind it. I'm all, you know, I've got my video glasses on, everything. I'm tech all the way. But one of the things I understand is that communities that are typically underserved are always at the bottom no matter what. So how have you thought about how was a mistake or so on and so forth? There's more equity in survival, if you know what I mean. Like, if there's going to be an over-reliance on this type of technology, because there will be, once it's proven and once it's put in place, how do we still not be at the bottom of that ladder?
Well, I really want to answer that question, but I just wonder whether one of the panel members, Marianne?
I'm happy to answer that question. So I think that's the point of us coming together today, is to tell you about the tech and where it's going, but also what's missing and where the gaps are. And it takes all of us to participate to address those gaps. So when I talk about the data, we all need to contribute to ensure that every patient that you know or every person you know tells the healthcare provider what their ethnicity is. Because if it's not recorded in there, it's just a missing gap, and it's a problem when it comes to designing tools like this. That's one element that I think that we all need to take responsibility for in terms of actioning. I like to talk about when you collect that type of data, there are lots of data points that change over time. Age changes, gender can change, your postcode can change. Ethnicity doesn't. You only need to collect it once. Like, it's not that hard for somebody to ask a question or for you to offer the answer. I understand there's complexity around the safety of being able to provide that data, and that's certainly something that teams need to think about in the way that they address it. But if we don't have that core element of data, we've got a problem. So an example is with the skin analytics tool for identifying early skin cancer. It's currently being rolled out at 9 acute trusts. Fantastic for addressing the dermatology waitlist, but it's a problem because it doesn't have enough data on darker skin to be accurate enough. So that's going to take time to build that data set up. So we need to really have community participation to engage in research, to engage in collecting that data so that you're not left behind. So.
One more. This lady's been waving furiously, Sam, so...
Well, yes, because you made a sort of almost flippant comment about knowing people with money. And in a sense, I wanted to know, so when are you opening the prospectus for small investors, for people like us who want to support our community businesses? When will the offer be open to us to help support you to make a difference?
I haven't got an answer to that question, but it's certainly one that we've discussed more than once. Something that we can take away and discuss, absolutely. Because what we wanted to do today, there was a space in the programme. We wanted to talk about AI and digital, and there was no one really who was able to kind of pull it together in the time that we had. So we offered to do that. So it's not a sales pitch. I think what we're trying to do is just demonstrate, as Ruchi said at the beginning, the art of the possible. This is the art of the possible. We've got a long, long way to go. I keep saying it again, it's my passion project. I love the NHS, very much engaged, but this is my passion project. So let's Rishi, do you want to come in real quick?
Just really quickly, we have talked about in the sort of margins of our development about crowdfunding. So the fact that there is an appetite, and like Marianne is saying, there's a lot of small.
Yeah, there are black small investment panels and dinners and various different organisations that do that. Can I say that black founders, so because we work with all the innovators, black founders are the least represented. Women are the second least, and then it's black founders. So we do have a number of programs. So in Kent and Medway, we've got Discovery Park. They are doing a lot of work around increasing the inclusivity and diversity of first founders for their companies and innovators. So there is support out there, but I think we all need to do a bit of promotion around what's there, and also encourage people to give it a go.
I'd also just want to say, I don't know, Ed, how many frogs have we kissed?
A few years of frogs.
Yes, absolutely.
And I'm tired of kissing. I can't find the print.
We've got time for one more. There's a hand back there.
I got you.
Thanks, brother. Thank you.
Hello, I kind of have two, I don't know if they're questions or comments, but I'm a genomics lead now, so thinking about genomics data, but thinking about if AI is rolled out, is there a risk of increasing health inequalities within different trusts that probably don't have funding's been cut, and so how do we kind of mitigate against that?
Can I answer that?
Yeah.
Right from the beginning, it has to be accessible to everyone, right? What we've done in how we code our systems is factor a global approach, not just from the language perspective, for the visual perspective, but also how you access the services and the products. For example, the first slide I showed you of the scenario, it's not an app. It's actually a very difficult way of putting an AI where you can just type in a browser link, no matter what device you're having or running, it will work on that. No need for downloads. So if you're out in rural Africa and you have a snippet of an internet connection, it will work.
But there's definitely a massive risk of widening health inequalities, and digital exclusion is at the heart of that. There are frameworks out there to addressing digital inclusion. There's one on our website at Health Innovation, Kent, Surrey and Sussex. Please look at it. They're free. As Bola said previously, there are lots of tools out there, but we need to be, A, identifying there might be a problem, and B, actually doing some action to try to make a difference. So yeah, I agree. Genomics, I think, is going to be the future. Precision, personalised medicine. We're talking about personalised cancer vaccines, for example. But where's the data for those from minority and ethnic communities? So yeah, we've got to do something.
Okay, one more. This young lady here.
Yeah, I think the problem is, I mean, Marianne, you just mentioned it, you talked about genomics, and I think that we're not really going to get anywhere, because we already recognize what the situation is, which is the disparity. So if we talk about genomic medicine, precision medicine, the disparity is already embedded in it. We represent the global majority. I've not heard anybody say that today. So anybody who, the ethnic minority narrative is very reductive. So when we look at the world in a global, in a global sense, we represent 80% of the globe. All right. So when you talk about ethnic minorities, that reduces us, and we're not. We are the global majority, because that's a global north narrative. The issue with genomic medicine is that 20 years down the line, the data with genomic medicine, 96% of it is from the global north. We know the reason why the data is not there for the global majority, and that is because of systemic racism and anti-blackness. So the conversation that we need to be having is, how do we engage our community? And it's not just us, because we didn't create it. It's the people that have the power and have the money. What do we do to engage our community, to say to them, it is safe for us to give our data, to put in our ethnic background without concern that, I don't know, the immigration people are going to come knocking on our door. What is it that we need to do to engage our community to say this is safe, and in the long run it will be beneficial to us? That's the conversation that we need to be having.
Thank you. I don't think there's anyone here would disagree with that, absolutely. What I can say, and it's not in defence of Genomics England, but they have reached out in the last 6 months to Inspire. Juliet and I have had meetings with them. They want to engage in this conversation. They don't know how to do it.
Yeah, the problem is, I'll tell you how they do it. Sorry to take over the mic. Genomics England, they're looking, like, for example, that newborn trial where they're looking at 200 plus different genetic conditions. There are already 2 genetic conditions that existed before Genomics England, which was sickle cell and cystic fibrosis. So those conditions were there already. So sickle cell was identified with the heel prick test, but they've not acknowledged that. And what they've done is that they've piled on a whole load of other genetic conditions to look at, but the conditions like sickle cell were not being sorted out, and the huge disparity between cystic fibrosis and sickle cell. So what they need to do is to acknowledge, recognise and do better.
Thank you. Well, as I said, I'm not here to defend Genomics England or Genomics South East, who we've had discussions with, but thank you very, very much for that. Clearly, the issues you raise, as I said, no one would disagree with at all. We've been asked to draw the workshop to a close. Unfortunately, we haven't had as much time for questions and answers as we would have liked, but as you would have seen, we've been running behind for most of the afternoon. We want to run a full-day conference on AI and digital and cultural sensitivity. We're pushing for that for later in the year, so watch out for that. Until then, can I ask you to give thanks to our panel, and the discussion continues. Thank you.
everyone, if you want to make your way back in the room so that we can continue with the rest of the day. Going to take your seats. Is Faye here? Okay. So everyone, if you want to take your seats, the next segment celebrates the exceptional research where contributions from the contributions presented by our summit today. We're honored to have two distinguished leaders who will present the posters and abstract awards. Professor George Holmes, Vice Chancellor and President of the University of Greater Manchester, and Professor Faye Ruddock, DL, Chair of the Caribbean and African Health Network. Professor Holmes brings extensive
good afternoon to you all, and first of all, my apologies to you for not being with you today at the Black Health Inequalities Summit. I did attend last year's conference and found it to be a remarkable event, a very inspiring event, and particularly the event afterwards at the House of Commons, where I was able to mingle with colleagues and learn an awful lot more about the work, the amazing work that people are doing. I'm the patron of the CAN, the Caribbean and African Health Network, and also the Vice Chancellor of the University here in Greater Manchester, used to be known as Bolton. And it's important to me to be with you today, albeit virtually like this, to emphasise the importance to us here in Bolton at the most inclusive, or one of the most inclusive universities in Britain, the importance of addressing health equalities, and particularly health equalities and equity for the black community. The event is supported, of course, by CAN, and of course we are massively encouraged by the work that they're doing here in the Northwest with us in Greater Manchester, and the fact they've inspired an event here in London is even more important to us of this critical issue for the nation and for all people involved in this. I do recognise the level of interest in this, in the summit itself, and the dignitaries that have been at the event and the keynote speakers and the topics of conversation, and it's a great privilege to me that you've invited and included me into this particular session to support this event today. The university itself is not only a university that's been in existence for 200 years, a mechanics institute through to a modern university, but also a university that's now opened its own medical school. And the medical school, the University of Greater Manchester, is now accepting applications for September 25, and it's got very buoyant demand. But our curriculum is very, very distinctive, indeed unique, in that it embeds health equity to produce professionals who are better equipped to understand health inequalities, because we believe that it's massively important that health professionals continue to keep this issue at the forefront of their mind to ensure proper equity in the treatment and support of patients from all backgrounds. So I wanted to share my ambitions with you and the ambitions of the university for extending the medical school into the dental school, into a school of dentistry here, and to point out how important it is that healthcare provision improves across this great nation. And whilst the work of the NHS is, of course, phenomenal, and colleagues, I met many colleagues last year from the NHS who are doing amazing work in pushing forward health equity and equality, there's still more we can all do. And I think that's what our university is committed to doing more all the time to ensure that things massively improve. My own passion is for widening access, particularly from underrepresented groups and communities, both to higher education and to other opportunities in life. And I'll talk a little bit about our Vice Chancellor Development Programme in a few moments. But our medical school itself will be unique and is designed to be an exemplar of good practice, working with our partner, the University of Leicester, who've been enormously helpful to us throughout this process. And again, have a very diverse group of students attending their medical school. I mentioned the Vice-Chancellor programme, and it's about trying to encourage individuals from classically unrepresented groups to join the most senior levels of higher education. This is something I've noticed over the last 20 years as a Vice-Chancellor, that there are there's not enough representation at the very highest levels in higher education from communities which are traditionally excluded. And we know there are all sorts of reasons for that, many of them not good reasons. And so in conjunction with CARN, in partnership with CARN, we have developed an access programme to the most senior leadership provision in terms of the Aspiring Leaders programme, to nurture the skills of leaders and to provide mentoring and coaching for aspiring leaders from underrepresented backgrounds. Our participants engage in residentials, workshops, networking events, the sort of thing you're doing today. They have one-to-one mentoring and coaching sessions with senior leaders, including myself and other Vice-Chancellors. And the result of this programme is to ensure that more individuals from the Black diaspora are represented at the very highest levels in higher education. And only in the last 12 months in this first programme, after the first few modules, we've secured already for one of our Black participants a Deputy Vice-Chancellor role in a major university. And this is a real breakthrough, we think, in terms of making sure that this programme demonstrates to people it's worth attending, because immediately people have started joining it, promotions have started to occur to the very highest levels. And this really is about our commitment to fostering diversity, fostering inclusion, and making sure that higher education leadership really reflects the communities that we support and develop and are passionate about. Now, today, of course, we're going to recognise poster presentations, and I have to say that I'm very, very pleased that there are 26 poster presentations selected for the summit, and the quality and the innovation of the research and the projects that are being showcased demonstrates the incredible amount of work that's taking place across universities and within organisations, and it's a privilege for me to be with you today to do that.
So, along with the
Professor of Health Equity, the university's, Greater Manchester University's Professor of Health Equity, Professor Faye Ruddock, will be giving out the certificates to winners on my behalf today, because unfortunately, as I said, I can't be with you. I've other commitments here in the north of England, but I wanted to be with you through this medium because it's so important that we connect on this issue. But Faye is with you, and Faye will congratulate the winners individually, but I'd like to congratulate the winners en masse here and the participants for their outstanding contributions and their posters. All that remains for me really is
I'm a bit scared now. I don't know if he's just going to pop up and start talking. So yes, along with Professor George Holmes, we are delighted to have Professor Faye Ruddock, DL, who is the chair of the Caribbean and African Health Network. She'll be presenting the award.
Thank you, Melissa. So thank you and afternoon, everybody. I have the privilege of presenting these awards, but before I start, I just want to say thank you to all of the speakers today. They've been absolutely incredible. I think we should give them all a round of applause. And I just want to say as well, just to say thank you to David, the CEO from the lottery, because many of these poster presentations have been funded by the lottery. So a special thank you for his presentation, but also for all the work that they're doing to make sure that all of the funding is inclusive. And that's what we actually need to see. So thank you again to the lottery for all that you're doing. So I have 7 presentations to do right now, and these are in no particular order. So as Professor George said, we have 26 that were submitted and selected, and these are the 7 that I'm going to call out now. So if the name isn't here, but you represent the organisation, please do come to the stage and take that certificate for them. So the first one is Tommy Specialist Midwife Helpline for Black and Black mixed heritage women and birthing people. So we just want to give them a round of applause. Amina Hatia, is she here? Anybody here from Tommy's? Okay, so we can hand that to them. Oh, she's coming. Nice pink top. We have the Healthy Church Initiative, a faith-based, culturally tailored health programme for black churches, and that is Shola Oladipo. Is she here? We have improving diabetes health outcomes for black populations via virtual events, and that's Dr. Joan St. John and Bernadette. We have Bridging the Trust Gap, co-designing AI for inclusive healthcare with black and minority ethnic women, and that is Sylvia Stevenson. We have prostate-specific antigen screening characteristics in the black and white community in the UK, and that is the JB Consulting. Is anybody here from there? Okay, we can hand that over later on. Then we have Healing in Our Own Space, co-creating a digital home for black women's wellness, and that is Dr. Vanessa Appiah. Anybody here to collect that one for her? And finally, we have Body, Spirit, Soul, a faith-based approach to health promotion in the African Caribbean community, and that is Farah Adiguni. So congratulations to everybody. Thank you so much for all your submissions. Please do have a look at all the posters that are outside of this room. Thank you. Enjoy the rest of the afternoon.
Wow, that was brilliant. So moving on, the next session brings us to the heart of our summit's purpose, understanding and addressing health inequalities through community voices and experiences. Jeffrey Olsen is the Chief Executive of the Bridge Renewal Trust, a charity dedicated to reducing health inequalities and building stronger communities in Haringey. His leadership has been pivotal in developing community-catered approaches that address the social determinants of health and
Thank you. Thank you. We are really excited to be here. We kind of got a bit worried because we are like at the end of the day, and I wondered how much energy might be in the room. And I've been practicing some. I can reveal a secret. I've been practicing some performances just in case. Yeah? But I don't need to do that, so that's great. I've got some friends I'll come to explain in a moment, but I think just maybe a slight reflection on what today is about as we come to the end. It's about health inequalities, and I think you need to look at what we're about to share with you, like our story in North London and how we try to address health inequalities. So look at it as a case study, for example, and we'll share with you in a moment. The second aim of today was also to empower Black-led organizations. And one of the things we want to share with you is how we've done that, working with community champions in the various grassroots organizations that we've been doing. And I think the third one is about developing sustainable partnership because, some was all started. I mean, I started by doing my own little thing in my own little patch. Then I discovered colleagues like Trevor, who is somewhere in the room here, has he gone? Right, doing something else in Enfield. And then a lot of our colleagues as well in Haringey as well, all doing grassroots organization, all doing our little things. Then the question then becomes, how do we amplify and build that kind of sustainable, trusted relationships and having kind of trusted people in trusted places. So that's kind of the story I want to share with you. If I can just quickly introduce then my colleagues here, I'll start in no particular order. Oh, by the way, if I forget to say this, I'll be in trouble. We are funded by the North Central London ICB. So thank you for that. Yeah, and I think Lizzie or someone is in the room, so there's evidence of that, yeah? Okay. Yeah.
Have we got the slides?
Yeah, we got some slides if you want to kind of share that for us. You can see a bunch of, it's like spot the logos, yeah? So all of those grassroots organizations we've been working with, Somali groups, Black Arts Production, they're in the room as well, using creative means to, do the message as well. And I've got here Sonia, who is, Sonia will speak in a moment, but Sonia runs a women groups looking at grassroots, but looking creative arts as well in trying to spread that message. And we have an alliance, as you can see there, because now we decided you can't just do it in Haringey or Enfield. Let's form an alliance that bring the two boroughs together. So we got Shai, who helped us to kind of coordinate that and make sure we're all doing, and complementing each other. Next slide, please. I've just remembered this is timed, yes? So in the next slide, really, it's about, you can see what we've done in Haringey, which is really, in the last year, focusing on prostate in black men and of Caribbean and African heritage. But working with the whole family there in trying to address that. The other thing we've been doing in Enfield, for example, is reducing barriers to and looking at the wider Eastern Europeans as well. But by the way, that's the one thing I've noticed here, and you can see it better at this space because it's not, this is about black health, but you can see the diversity in the room, and that really gives me a lot of encouragement as well because you can't do it by ourselves. Also working with black African Caribbean groups, youth communities, and so forth in Enfield. And the whole idea is to look at the wider determinants as well, not just what may be the thing that normally deal with. Issues around trust is a big issue. The usual stuff around language, we've tried to address that. Cultural competency, all of that we try to address, but sometimes we forget the wider determinant. And just one example of a sort of elderly woman who doesn't speak English, by the way, but very little, just enough to communicate. And she told us that every time I see my language in any poster or in any communication, I feel included. And that tells you a lot. You don't need to do a lot to be able to include and make sure people are engaged. Next slide. Yeah, so in terms of our response then, this is what we've kind of started to do. And you can see at the far end of the picture, it might be too small, but you can see those are some of the road show and the road works. We go out in front of, African, food outlets, Caribbean food outlets, restaurants, supermarkets, everywhere, just taking the message out about prostate cancer, for example, out there, and speaking to the whole family as we find them. You can see, the picture right at the top, maybe this end, is involving, for example, the council in that. So that's the mayor who has really lent us very, strong support. And somewhere in the middle there, you can see the picture also of, the different workshops that we've been trying to do to bring different communities together. So the whole thing really is about collective action, which we've seen previously mentioned. So if I can just then take us on to the next slide and then get my colleagues to share a bit more. And that's a clue for Sonia to step in. Okay. Sonia, thank you.
Thank you. Oh, hello. Can I have the next slide, please? No? Oh, there's another one, there should be. Oh, okay. Prostate Health Weekend.
But
There it
it
is.
fungus and inflammation in the body. And certain medicines can get rid of that. So eventually I was diagnosed with it and I went to the North Middlesex Hospital, where I must say I would like to congratulate the North Middlesex Hospital, and I hope to join them in doing fundraising because they are fantastic people.
Okay, so that was just a clip from our Prostate Health We Care programme. And there should be another slide. Coming. Another one?
Yeah. You can just...
Okay, all right. So men of African and Caribbean and Latin descent face limited access to early PSA tests, prostate cancer checkups, and reliable prostate health information. Now, I know we all know that, but I'm just mentioning this because one thing Jeffrey didn't actually mention is that Haringey was one of the boroughs that was selected to be part of the 8-borough programme when the Inspire programme first started. So since 2021 in Haringey, we have delivered a black community's healthy living and high living and lifestyle fair since then, engaging numbers over 200 and 300. But going back to the Prostate We Care, what we did, we organised a structured, hybrid and outreach approach using culturally sensitive language to build trust and deliver accurate, actionable health information through personal stories, roadshows and expert clinical guidance. And what I mean by that is that all the partners in there, there was no duplication of services. So the basketball team, the RISE team, our team working with families and all the others, we never had the same man come to one of the events, which just showed the need. And what we also mean about structured, it was structured. So we had online presence, but we had individuals in the community advocating for the project, so people knew who they could contact, and it wasn't something that was just a faraway myth. People could get involved in the roadshow. And what we definitely did, we went out to the community. We didn't expect the community to come to us in the same old spaces. We went to libraries, we went to churches, we went to the pensioners groups, we went to all the places where we're going to find men that are not going to step forward to get a test, and we worked with them. Just, we didn't use jargon, we didn't use language like that. We were just emphasising the importance of getting a health check, whether it's prostate or anything else. And it was very successful, which meant we could signpost individuals to clinical experts. Okay. So the impact of the work that we did was increased awareness and access to early detection resources, community-led engagement and surveys. Yes, we collected surveys as we went along. We asked people to give us your data. We really did overcome the challenges where people don't want to share their data, they don't feel confident with it, but we explained the importance of having the data because it's something that will benefit you in the long run. And I think we were able to do that because what we built up as a grassroots organisations, we built up trust. The trust is the currency, no matter how you look at it. If people don't feel comfortable with you, they don't trust you, they may give you information, but actually it might not even be valid, you might not be able to use it, and it's a waste of an engagement. So we've built up trust, and the communities we work with, they support our programmes. And one of the things I wanted to say is that one of the questions people always ask us, well, what's the cultural approach? And we always think about this and we say, well, a cultural approach is if you put something on, the food is relevant to the group who are coming. Okay, if someone has got diabetes, please don't be giving people lots of more sugar. Do you know what I mean? A lot of people are lactose intolerant, please put on different types of milk. Other thing as well, what we realised is having respect how we address people. Our elders, they don't want to be called Doreen. They want to say Mrs. whatever. Do you understand understand what I mean? Because, you know, it's a respect thing. You know, we don't want that. It's this casual way that people are dealing with us, and all of that we changed. We asked people, how do you want us to address you? You know, we asked the question, and by doing that, people shared so much information we would not have got under normal circumstances. But the community-led engagement roadshow, the surveys increased positive responses to research involvement and supported network strengthening trust in the healthcare pathways, and helped individuals and families gain the knowledge they need to enhance this was about prostate awareness. So we took a holistic view and we took a family view, and we explained to the men we work with, let's say, who are Uber drivers, you know, we went to where they are, literally, and we said, if you're not here, what's going to happen to your family? You know, and we broke it down like that, where people actually had respect for themselves, because it isn't about us, it was about taking care of yourself. And the other thing that we did, and we did very well, we reminded our community that we have got a long-term investment in the NHS, because most of us have got family members for years that have made a positive investment. Nurses, doctors, the people that did the catering, the porters, it makes no difference. They've invested in a service that we are entitled to have. Okay, so I think they've told me that's the time. Thank you.
Hi, so if we can go to the impact slide, please. Throughout the slides, they went on very long, and we don't have very long, but you will notice that we had put Haringey, Enfield, what we did, blah, 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 blah. That's what we did in year one. And what we realised is that we were both receiving this funding, and we were both doing really important work in our communities. So within Enfield, we were working really closely with the Black African and Caribbean community, but also with the Eastern European communities, the Bulgarian community, the traveller communities, people who, as Sonia said, are traditionally ignored. They might not even have a GP that they're registered with. So it goes beyond that whole, just give them access. Well, if they don't even know how to have access, what are we going to do with that information? So if we then move on to the last slide, please. What we realised is that it's really important for us to have this alliance. So for year two, what we did was we came together and we built this Haringey and Enfield cross-borough alliance, because actually we could learn from Haringey, Haringey could learn from Enfield, and we didn't have to duplicate information, as Sonia was saying as well. We could just strengthen the work that we had done. So in year two, our impact we intend for it to be about heart health, and actually, because heart health is such a broad topic, it can apply to any community in the way that most impacts that community. So for Black communities, we're going to be talking about hypertension, we're going to be talking about diabetes, all of those things. We're going to be talking about fitness, about food, all of the stores that you all have downstairs, all of those things we're thinking about, and we're trying to connect with you. A lot of you we have connected with, actually, but there are others of you I've taken your email addresses, and I'm sure you have, and we'll be in more connection, because it's really, really, really important for us to continue this work that we've been doing. And maybe next year, who knows, it's Haringey and Enfield this year, maybe next year there will be 4 names, 4 boroughs up there. So thank you so much. I'm going to hand back to Jeffrey.
Yeah, just to finish then, I thought I should talk about who wants to be a millionaire. Yeah, shall I? You probably wonder. I think we're the only 3 acts, speaking. Yeah, because there was an opportunity, and thank you to LDNinspire and Khan for giving us this opportunity to share our stories. But then, I could have presented that, and when you're not sure, you don't just call your friends, you bring them along. Yeah, so that's what I've done now, and I hope you've enjoyed it. Thank you very much.
Thank you very much for that. So next we're going to have a short video be played on the screen next to me to announce the Black Healthcare Awards. The Black Healthcare Awards were established to recognize and celebrate our healthcare professionals who are the backbone of our healthcare system. Please watch this video and learn more about making nominations and how to be involved.
Hey!
How often do we get to celebrate black people? How many times do we get to celebrate black healthcare professionals? Not enough. Nowhere near enough. And that is why we have created the Black Healthcare Awards. So my name is Professor Faye Ruddock, and I want to tell you why we've created these awards. Last year was our inaugural. This year we're doing it again because it was so fantastic. We had over 500 people celebrating, recognising many of our healthcare professionals that are doing brilliant, brilliant work. We celebrated, we had many categories. We had over 27 categories last year. But we've listened to you and we've reduced it slightly. So we've got 23 this year, and these are 23 that you could be nominating to. This is a moment where we can be shining and uplifting each other. We at Khan have created the platform for people to nominate, to put people forward, and our external panel of judges will be there to make the judging for these awards. We know that black healthcare professionals are the backbone of our healthcare system, but we just need to celebrate them and recognise them a lot more. So you ask me how you can participate. There are two ways in which you can participate. The first one is going across on the screen, where you can go onto the website and you can complete the form, nominate somebody, a colleague, somebody you work with. You can nominate a mentor, somebody, because many people have, mentors that support them. You can nominate those if they're from the black community. You can nominate a coach. You can nominate yourself, because we know ourselves best and we can put ourselves forward and we know exactly what we're doing and what we want people to celebrate. So you can put yourself forward, and please don't be shy to do that. The other thing that I just wanted to stress as well is that we want nominations from right across our healthcare system, not just providers in our hospitals, but we want nominations from primary care, we want them from universities, we want researchers, we want people from the voluntary sector, we want from the social care sector as well. We also want professions such as pharmacy, such as, laboratory technicians, we want allied health professionals, we want advanced practitioners, nurses, doctors, you name it, we want professionals from right across. So please do think far and wide about who you could nominate. There's always someone that you think is absolutely amazing and that you want to nominate. So please be part of the celebration. I still get goosebumps thinking about what it was like last year. It was absolutely fantastic. We were there with most of our patrons. We were there with the judges were there, the communities. We had people from right across the generations celebrating. And many people said, my gosh, I didn't even know these people existed. It was fantastic. So please do not miss out. Buy your tickets. They are on sale on the website that is again on the screen. Take this time to nominate. It takes about 5-10 minutes to put a nomination in. If you are struggling with any part of the nomination form, please, again on the screen, there's some information about where you can get some help. But let's celebrate. Let's inspire the next generation. We'll see you in July the 12th at the Park Plaza at Westminster. Thank you.
Thank you, Faye, for that. Before we move on, I'd like to call the next panel to the stage to join me for our final plenary session. We are joined by Katie Saunders from Social Finance, Professor Ivan Brown, and also David Knott, who you heard from earlier, and Rosie Mughal, who's the Associate Director for UK Policy in Oncology at AstraZeneca. If you could all please make your way to the stage. Thank you very much. And one last thing on the Black Healthcare Awards, just to note that you can look in your tote bags to be able to scan the QR code for the nominations. We need to celebrate our healthcare professionals, as you've just seen, from the voluntary sector, primary care, social care, all across the healthcare system. And please make those nominations for your fellow healthcare professionals by the by today, and for the awards on the 12th of July. And please do so when you are able to. But I'll now pass over to the panel for the next plenary session.
Thanks, Nick. I'm just wondering if we can get some microphones for the panelists. Okay. Hi, everyone. So my name is Charles Krakodwe, for those who don't know me. I'm the Chief Exec for the Caribbean African Health Network. And you may be wondering what we're hoping to achieve from this session. Last year, we held the inaugural Black Health Summit. And this year, one of the challenge from our co-chairs, as well as some of our funders and our sponsors, is that by 2026 summit, we need to know what is happening and the difference the summit has made, and hence why we're having this session. So it's more about a call to action. So we're going to kick off. You may have heard or you may know some of these faces, but they're going to start telling you, a bit about themselves and give you a couple of reflections from the day. Then we can delve into what needs to change between now and 2026. So I'm going to start over the other side with David.
What do you want to know, Charles, about me?
So yes, we heard from you earlier on, but for those who are not aware, or I'm sure many of you will know, but within the voluntary sector, funding is very critical. You could have the brilliant ideas, you could have fantastic proposals. If nobody's going to fund it, then you're stuck. And the reason we are absolutely delighted to have the National Lottery Community Fund here, headed by the Chief Exec, is the fact that health is one of their 4 community-led missions. And then also the recognition that tackling structural systemic racism is really important. It's also refreshing. So, David, a couple of reflections from the day. You've heard from other speakers, but yourselves as a funder, taking health inequalities really seriously. What are some of the key takeaways?
Yeah, thank you, Charles. And I just want to say this is like a personal agenda for me and a commitment from us all at the National Lottery Community Fund. When we looked a few years ago, coming out of COVID, at what people wanted from the National Lottery going forward, where we thought National Lottery had made a difference, but what more was needed, there were some of these themes that really came through so powerfully. Health, young people, connected communities, environmental action. But fundamentally, it starts with community. It's about trusting communities, about putting resources into communities, and doing that in a way where we've got an absolute commitment to equity, diversity, and inclusion. And we use equity, actually, rather than inequality, because we think equity actually demands something deeper. It demands us actually to recognise and address the historical underserving, the systemic racist, other causes of observed inequality. So I think that was a big step for us as a national institution, actually. And you'll see it in our strategy. It's quite a short document, actually. It starts with community. We didn't write a long tome, several hundred pages. We wanted to keep it accessible, actually, something that people can tangibly feel. So I encouraged to look at that, to listen to some of the sort of stories. I think Sandra is here, one of the game changers that we celebrated when we had the 30th anniversary of the National Lottery in the autumn, and incredible work that she's doing with black mothers and on black maternal health, and she was speaking just downstairs now. Charles, it's been my great privilege to come here for the second year, and as I said at the start, I thought last year was, if it was starting the conversation, today we're building on that action, and we've heard from so many powerful speakers about the scale of the challenges, but also the hope that there is in the action that's being taken. And I hope when we come back again, we'll be holding ourselves to account for that. So, yeah, just a few reflections for me so far.
Thanks, David. I'm going to come back about some percentages, but we'll talk about that later. So next, we're going to hear from Katie Sanders from Social Finance. You may be wondering, who they are, but Social Finance is one of the co-sponsors for this summit, but then also they're taking health equity really seriously. And Katie, you've been here all day. A couple of reflections from yourselves.
Thank you. Yeah, it might surprise you, I'm passionate about using finance. Yes, finance in terms of building trust, bringing different people together, but also driving sustained change. And I guess a couple of reflections from the day. So, the theme of the day is around co-design and community leadership. I think that goes without saying when we talk about services, but we really need to go further, and we've heard some speakers throughout the day. We also need to be co-designing budgets. How are budgets set? We need to be co-designing policy. We need to be co-designing the system. Something that struck me throughout the day is the importance of language. We don't have high-risk people, we have high-risk systems, and we need to be co-designing the systems from the inside out. The other thing that I'm struck by is sustainability. We all work in health. I am determined to cure pilotitis, which I think a lot of community organisations are suffering from through no fault of their own. So we need to be thinking really creatively. Grant funding is fantastic, but then it comes to an end. Then there's a cliff edge. How can we be engaging with finance teams? How can we actually be funneling grant funding in a meaningful way through the system so that it's valued and so that impact is measured? I've got lots more to say, but maybe come back to me.
Thanks, Katie. So we're going to now hear from Professor Ivan Brown. For those who may not know, he was Director of Public Health in Leicester for a long time and during the pandemic, but now has moved on to De Montfort University, but also early in the year awarded OBE for his services to public health. So, Professor, over to you, some reflections.
Thanks very much, Charles. So for me, I carry my background with me wherever I go. So I walk in here and I already knew what I wanted to say. So I was looking for specific things. The first one being community. There's some things I learned from the pandemic, and irrespective of what national leaders may tell you, community counts. And community exists. And one of the things that I wanted to make sure that we were doing and was reflected in our conversation is the power of community. I go so far as to say community is the only show in town if we are genuinely thinking about meaningful change in terms of inequalities. And how do we engage communities? I really get frustrated when I hear people saying, we need to hear from the black community. Or maybe it's just me, but I don't know black people who don't tell me what I need to know. So, that might be my thing. But what I've noticed is that we don't go out and hear, and we're not humble enough to listen. So one of the things I wanted to see was something around that, and I was really glad to hear that. The other thing was about localism. In order to make those changes, they have to be tailored, they have to be targeted. I always talk about Leicester, that's my home city, that's where I was born. So I'm always going to champion that, even though we're in a relegation zone at the moment. But nonetheless, I will always champion, but I recognise that my experience in Leicester is going to be different from an experience in London. And I have to make sure that whatever we do is tailored to our communities. And I've heard conversations, it's even interesting looking at the stallholders, where people were talking very much around what's happening for them. And we need to keep that narrative going, be proud of it being local. I'm going to go to the other ones quickly, Charles. I know you're looking at me. The other one is, one of the things we learned is if it's ground up, can we make sure that the money follows? Can we make sure that if we are delivering at a local level, if we're delivering at community level, let the money and decisions around the money be taken around that level as well. So that was a kind of one of the key things. And I'm a public health person. I'm always going to talk about data, but data only counts if we're included in it. And listening to some of the things about the observatory, etc., we've got to really push around making sure we are included in data, or else, let me tell you, we will just be ignored. Yeah. So we've got to be very serious about that, and we have to have singularity of purpose. And that's what I'm hearing. I'm hearing that we want to make things better. Let's get around that totem. Okay.
Thanks, Prof. So now, Rosie, I know some of you get a bit anxious when we mention pharmaceuticals, but it's always good if we can use, money from, to do good things. And, we're delighted to have yourselves as one of our sponsors, but, it's good to see a global pharmaceutical taking health inequalities seriously. I heard you speak at the Royal Society of Medicine in January, and through conversations you co-sponsored today as well. A couple of reflections and thoughts from yourself.
Thanks, Charles. And yeah, a few of you may be wondering why AstraZeneca's on the stage, and it is that it's our global commitment around improving health equity. I just want to start off with actually a bit of an anecdote before I move on to reflections, which is about a year ago, I was in the audience for a panel like this, and so one of my peers in industry put their hand up and says, well, what can industry do about that? And the panelist's response has stuck with me, and it's really fed into the way that I communicate internally what we should be doing around health equity, which was, historically, you have been part of the problem. And there were a lot of raised eyebrows, but also a lot of nods in the room when the panelists said that. But then they said, looking forward, you have to be part of the solution, which was why when I was invited to join this panel, rather than shying away from the conversation and what could be quite an intimidating thing to do, I thought it was the right thing to put ourselves out there and join that conversation. And I think that brings me back to my first reflection, which is going back to the point Sedi made right at the beginning of the day: do not observe. I'm not here to tell people we've got it right at AstraZeneca, we know exactly what we're doing, we're funding all these amazing initiatives and whatever. I'm here to listen and learn, but critically I'm also here to engage and take these messages that I've learned today back to my organisation. I think the second reflection picks on a point that, Katie, you touched on as well. It's around sustainable partnerships. This is a really big thing that I champion internally. I think it's amazing that we can provide grant programs, and that's a really great short-term thing we can do, but increasingly we really need to be making sure it's more than just grant funding. We're partners to communities, to systems, to individuals, so that we can make the case for embedding the changes that we bring in. Because too often we do hear about amazing initiatives that are brought in, and they say, wow, it worked, and look, you increased uptake of breast cancer screening, and then the next following year, NHS isn't going to fund it. We have to then try and make the case internally to fund it. We need to find ways to work together to make everyone say yes and say, actually, these are initiatives, pilots that must be embedded into communities. And I think that goes back to maybe my third and final point before I hand back, which is we recognise our responsibility as a company, and it goes beyond grant funding. It goes back to our reason as a business, which is driving innovation and medicines equity, that we leave no patient behind. So whilst there are short-term partnerships and grant funding programs that we can do, the more important aspect is that we're embedding a health equity mindset into our business, that we're establishing long-term relationships. And I'm really pleased that this is our first year supporting this platform, but I'm really excited about where our relationship with Calm will go and the opportunities we can provide together. So I'll leave it at that.
Brilliant. Thanks, Rosie. Just to say that we're expecting Esther Mukaka, who is the NIHR lead for, diversity, but she's having tonsillitis, so unfortunately she couldn't be here. And also just after 4 o'clock, I had a final apology from the Secretary of State's office. He really wanted to be here, but many of you know budgets. So anyway, the other thing to say before we hear the final bits is you can join in the conversations about what needs to change. Yes, I'm gauging the temperature, that's all right. You can join in the conversations about what needs to change, but we're really serious. And the topics we selected for the workshops are all really important. within that are two of the manifesto commitments for this current government that we want to make sure, from the workshop notes, as well as opportunities for people to join task and finish groups, to really determine what needs to change. So please, if you did not register, make sure you register, because we're going to put a call out for people to join task and finish groups. I heard from the lotteries workshop, the people wanted more time. So we're going to have a health and tackling racism task and finish group, diversity in digital and AI. I know some questions were thrown to, those in the AI, workshop. But then Black maternal and neonatal, health, what needs to change? What is our clear ask of government? And you heard from Paulette earlier in the morning. But also Black mental health, considering the current Mental Health Act will be revised, reviewed, whatever you call that. As a community, what needs to change? And that is why we need your voice on the task and finish group. And then the long-term conditions and CVD, but also the 10-year health plan. We may have a few weeks more to feed into that. So it would be great to hear from yourselves. For some may not know, there's the stakeholder sort of partner council that meets on a monthly basis, but also climate, race, and health inequalities, indoor pollution. Some of you will remember the 2-year-old from our community, but also someone who died from asthma from our community. So what needs to change? We need to be part of. And then the final one is genomics. It's really, really important. Like Sadi said, we are not observers, but part of it. So we have just under 2 minutes. I'm going to go round. By next year, 2026 summit, what do you want to see change, whether in policy, in practice? David, I know you can be bold, ambitious. In terms of funding, do you have any quotas, or, through the task and finish group, we might work with you in terms of, what people need to see, because data really matter. So I'm going to start with you, Rosie. What would you like to see change?
I think we had a really interesting, important session around AI. It's moving at pace. I'd love to see some really tangible work streams on how do you ensure it's inclusive, and how can you bring industry along with it. I know it's something that globally, as well as in the UK, AstraZeneca is very passionate and keen on. So we have to be part of that conversation too. So I'm excited about that.
What I'd like to see is us really tackling the inverse care law. Those that have the greatest need get the least health. We need to switch that, and I want to see what we're doing to try and just nibble away at reducing that.
I would like to see a real shift in what I view as a kind of improportionate burden of proof. So we spend a lot of money, time and effort on things that we know are not working. We've got great ideas and things that are working, and I think that we ask way too much in terms of evidence, and we just need to make that shift. And if I may, it's really my mantra is progress and not perfection, and I feel like we sometimes ask the world of things that are new and innovative, but actually it's common sense and it's good care.
I so agree with all of those points. I think the AI one, the pace of that is moving so quickly. I'm not even sure a year is. We're gonna have to get on this faster. There's some really important conversations that need to happen now about what AI really means for us, how that is not going to further exacerbate biases and inequality, how that changes the nature of community, and what does that mean for public services and institutions and charities. That's big, it's happening fast. I guess my thing would be really act local, start now, and there's an emergent agenda here. Last year, it was just before the election, wasn't it? So we're hearing big changes. We're on a journey in the National Lottery Community Fund. I hope in a year's time we'll be having a deeper conversation again about these big questions, data, finance, governance, and that we're learning, we're adapting, and holding ourselves to account for that in the transparent way that we should.
Well, massive thanks to all the panelists. And then I suppose from me, the final thing is we know things are moving really fast, NHS England going, ICBs and all that. But for those who may not know, LDNinspire program, for what we do has been co-funded by the 5 ICBs across London as to what will happen post-match. So probably next week, we don't know yet. So I know there are some funders in the room. It will be good to keep Inspire on the show so that we can continue to do what we do right across the 32 boroughs of London and beyond. So if you are able to support, come and speak to me and I'll put you in touch with our co-chairs. Massive thanks to you all for your time. Thank you, panelists.
Okay, everyone, we're slowly coming to an end, well, quickly coming to an end. It's almost 4:45, but before we end the summit, I'm about to introduce somebody who you may have seen here already. You might have seen his hat. He needs little introduction. I'm honored to introduce a true entrepreneur, a musician, a chef, and an inspirational figure. Levi Roots has become a household name since his memorable appearance on Dragon's Den with his reggae sauce. But Levi's story is about much more than business success. Born in Jamaica and raised in Brixton, his journey represents resilience, creativity, and the power of staying true to one's cultural image. Throughout his career, Levi has remained connected to his community roots while building a remarkable business empire. Beyond his entrepreneurial achievements, Levi has been a passionate advocate for community development and has used his platform to inspire and support young people from diverse backgrounds. Today, Levi joins us to share his insights and inspiration as we conclude our Black Health Inequality Summit. So please stand up and give a round of applause for Levi Roots.
Lord of mercy. Unfortunately, I don't have any sauces to give away right now, but I can safely say they're in actually every store across the UK, so you don't have no excuse. Food has been my thing, it really has, and ladies and gentlemen, distinguished guests, it's an honor to be here to speak with you today. I've usurped myself with your blessings over the years, and I feel it's a pleasure to come and talk to you about food and drink and how we can use that to change our lives. I know there's been a lot of talk about how we can get different kind of help to help us to change our lives and to be better, but I really do believe that in some ways we have our destiny in our own hands, and if only we can change a few things, then I'm sure that we'll be on our way to a better health. But we have a problem. People of Black African origin are up to 3 times more likely than white people to develop type 2 diabetes. High blood pressure and obesity are also a huge problem within our community. So I'd like to talk to you about reduction of traditional foods. Also our change in our habits, how it can improve our health and our well-being. Most of us are already at a disadvantage because of where we live and the size of our salaries. This will eventually determine the level of care we receive. And if one were to develop type 2 diabetes or prostate cancer or any other illnesses, they play a huge role. So we are already at a shortcoming. But that still doesn't stop us from doing a bit of self-help by changing a couple of things. And so, our food and our eating patterns is always a good place to start. You are what you eat. I'm sure you've heard that before, and there is some truth in it. But to some of us, change can be really quite scary, especially for Caribbeans blacks, because any suggestion of tampering with our eating habits. Round of applause, please. Come on, fast. Any suggestion of tampering with our eating habits or our traditional cooking styles and the foods we love, that can prove to be very painful indeed. Painful for anyone who dares to critique our oxtail and butter bean stew, our spicy curry goat and white rice, our cow foot and rice and peas, etc., etc. You will hear cries of sellout and even the fashionable call of cultural appropriation being thrown around. But what I am saying is to cut down on the wrong stuff, which we so love, including those extra added salts and sugars. They are what's doing the real damage. Check this. The diabetes.org site says that the Black Caribbean male and female are at a greater risk than any other ethnic group, including Black Africans, Bangladeshi, and Pakistani. Most importantly, I noted that it also says that all of the serious diseases, type 2 diabetes, they have the strongest association with obesity. No one is saying to completely cut out traditional methods of preparing our food, especially for meat and fish. But you really need to get to taste the flavors of your food and not only the powdered seasoning, which is usually slapped on 24 hours before cooking the day of consumption. Trust me, I know about well-seasoned. But what was good back in the day when our mothers and grandmothers used to cook that way, when sugars and salts and seasonings were all just about taste and flavors back then. But now, to us, they have become a danger to our health. Back in the day, people were much fitter. They ate organically and had less pollution and no GM food to deal with. So their internal system works perfectly, turning the good stuff into energy, but then rejecting any toxic elements that got into their system as waste material at the end of the day on the toilet. Remember the old saying, what doesn't kill you? Fatten you. That came from our elders. But it's not strictly true, is it? They didn't know what we know now. Our ancestors, they also ate less too. Mealtimes were punctual and not a lot of snacking went on in between meals either. If they did snack, it was mainly on fresh fruits, shoots, seeds, and nuts. And because of it, people slept better, worked harder, and lived longer. But sadly, our pattern today, our bodies are more constantly under attack by new super strains of colds, flus, and all sorts of epidemical viruses. So by the time we get to our middle ages, our immune system is pretty much burnt toast. So I do believe that it is not what you eat, but more about how you cook it, how you prepare it, and finally, it's also about when you actually consume and enjoy that food. I much prefer the old lyrics that says, it's not what you do, but it's the way that you do it. Nowadays, I always try to measure my added seasoning with one eye on my taste and flavor mantra, which is too little is better than too much. Still, I never truly understood how the body works when it comes to what it did with our food after we have swallowed it. Like many of us, I took that part for granted. So recently, I started to pay a lot more attention to that and my weight and my wellness. Take regular checkups. Don't wait until you're ill before you take action. Be one step ahead and protect yourself against type 2 and other illnesses. For me, my path to change started when my 7-year-old son, Christopher, called me fat. I remember we were playing around one day when he said, "Daddy, I love your nice, fat, squeegee belly." And I was like, Lord have mercy. I knew I was a little bit overweight, but I wouldn't have said fat. No. At 16 stone and 6'1" body frame, I thought that was not bad at all. But in fact, I'd been increasing in body weight for about a year without even realizing, until my Oswald Boateng suits wouldn't fit me no more. And I recalled that I had 54 Oswald Boateng suits. And they're all now in my wardrobe, can't fit me at all. Working in the food and drink industry didn't help either, as creating recipes, doing cooking demonstration, sampling, testings, and tasting products daily, that all came with the territory that I was in. Plus, I had been taking blood pressure tablets daily for many years after being diagnosed with hypertension, and the side effects of the medication were causing me some problems. And so with Christopher's words of fat, squeegee belly kept ringing in my ears, I decided to act, to lose weight, 2 stones to be precise, and to bring my blood pressure under control. And I wanted to do it naturally without medication. Firstly, I needed to take on an online crash course in human biology on how the body works, particularly when it comes to nutrition. What I discovered had changed me forever. And now I'm actually feeling so much better than I've ever did. I lost the 2 stones in quick time and lowered my blood pressure rate to an all-time low. All by paying attention to what I ate and to when I ate it and how I ate my meals. I learned what I needed. I needed to respect and pay attention to my gut and to protect my immune system, because those guys, they had been working overtime. My digestive system was fatigued and exhausted. They needed a break. They needed some well-earned TLC. Like most of us, I was always eating, drinking all day, every day snacking, chewing, swallowing, breakfast, brunch, lunch, dinner, supper, bedtime, snacks, etc. And it didn't matter when. If I was hungry, I ate. And it was that simple. And the worst, most troubling thing was that most of the food that I was eating and drinking, the ones that I consumed, is that they were not the healthiest. They were foods which were so much tougher for my overworked digestive system to deal with. Give your gut a rest, guys. My advice, if it comes in a tin or if it's already cooked, then it's probably not good for you. That is the rule. The diabetes.org.uk website tells us that diabetes remission is possible, and that remission is strongly linked to weight loss. I'd always thought that losing weight had to include rigorous exercising, lifting weights, and a lot of running around parks. And me yet running, I got to tell you that to them, and I like that. And the thing was, I hadn't been to a gym in about 20 years, and I wasn't planning on joining one just then. My research is showing me that it is possible to lose loads of weight and to do it quickly without rigorous exercise. I began my weight loss journey with the reduction of 4 most dangerous items to us black people: sugar, salt, starch, in what we refer to as hard food, which is, for those who are not that way inclined, your hard food is your yams, your dumplings, your green bananas, etc. And bread, of course, which is the flour. I call them the devil's essentials. I'd enjoy them all my life, never stopped, not even thought about reducing them, but they had to go at least for a while. And I can honestly tell you it worked amazingly for me. The weight simply just fell away right in front of my eyes. I know I may sound crazy, but believe me, guys, my body took to it like a duck to water. It's like this: when we overwork parts of our bodies, or we get strains or muscle fatigue, usually the most sensible thing to do is to simply give that particular part of the body a rest. Chill out. Let the body repair itself and heal itself. So the same must stand for when we are internally feeling unwell, like when we are under the weather, tired, for no apparent reason, not sleeping well, etc. These are all signs that perhaps you might need to take a look at your eating patterns and to perhaps get a full body MOT checkup. My best advice is to reward yourself with some good nutritious food and to take regular junk food holidays, away from all that processed stuff. Reduce all bread, dairy, and carbohydrates for a while at least, and allow your body to take care of you naturally. Only then you will get the best of yourselves. It's all about taking control of your life, because you are responsible for your own health and your well-being. Perhaps the challenge of food reduction might be difficult for some people, but the fact still remains that cutting down on certain foods and changing your eating patterns are by far the first and best step towards losing weight and protecting yourself from diabetes, hypertension, and other heart diseases. So I am here, ladies and gentlemen, to reach out to everyone, especially to people like me from Afro-Caribbean origins who are at greater risk. Please do not wait until you have developed these conditions before you get to know how easy it is to avoid them. So eat less, be blessed, think of your health, and give back to yourself. Big respect. One love.
Thank you very much, Levi. As we approach the conclusion of today's summit, this next segment will feature closing remarks from our LDNinspire co-chairs. They will reflect on the key insights, discussions, and commitments that have emerged throughout the day and outline the path forward as we continue our collective work to address Black health inequalities. Please welcome the LDNinspire co-chairs for their closing remarks. Thank you.
It'd be really good to know if you feel that today has been impactful for you. How's it been? Good. That's good to hear. So I think we've had some amazing speakers. The workshops we've had so much positive feedback about, and the stalls downstairs. So I hope there's loads that you take away. On the feedback that we had up, there's a QR code earlier. We'd really like you to put the actions you're going to take after today. So what are you going to do that's different, and what are you going to do in your kind of organisations or your field of work or your lives that's different to really start to impact the inequalities. I think we heard lots about hope today. I think last year Reverend Les, who spoke, talked about hope, and so did Professor Boller today. I think that's really important in terms of that we don't lose hope, because it can be really tough when there's so much inequality and how we address it. I think the other thing that Professor Boller spoke about was the movement, and you will have known from our new mission, we are now calling Inspire a movement, and we want you to be all of a part of that movement, because that's when we actually have change. So we want to stay connected with you all. I think Charles spoke about if you're interested in getting more involved, or with the task and finish groups or the steering group, please do contact us and take action. So yeah, I hope you enjoyed, and enjoy the networking afterwards, and let me hand you over to Sedi.
It's really hard not to get emotional. I was worried about today because I thought, how do we top last year? How can we be more impactful? How can we connect more deeply? And you know what? Mission accomplished. I think I said two things last year. One, I talked about a cost of change moment, when I said real change only occurs when the cost of not changing outweighs the cost of changing. I thought we'd reached that point last year. I think we're still there. We don't have a choice, ladies and gentlemen. The other key message to leave you with is that none of us can do this on our own. It doesn't matter, from my perspective, whether you're a chief executive, whether you're a director, whether you're a community activist, or whether you're someone who just wants to make sure that you're around to walk your son or daughter down the aisle in 10, 15, 20 years, or whatever it may be. This is really all about us. It's about me, it's about you, it's about us. What I hope is you haven't been a spectator today. What I hope is that you've used every opportunity to engage with people, be inspired by people, and to do your fair share of inspiring. Again, mission accomplished. The speakers we've had today, I think, have been absolutely amazing. Absolutely amazing. And Levi, I tell you, you've left us all with some very heavy thinking to do. How can we make decisions every day that work for us? It's really hard. We talk about health inequalities, and we know there are people out there trying to feed their families on £3 a day. It's really hard, but there are things that we can do and be inspired by. So Levi, thank you for inspiring us. Really appreciate it. So, I don't know, Charles, whether you've got a few words to say. I just really want to thank you from the bottom of my heart. It's been a wonderful day. You've made it a wonderful day. Thank you very much.
So, ladies and gentlemen, once again, massive thanks for all your time. Can I apologize for the rocky start in the morning? But we got through. We were able to, turn things around. So thanks for that. I'm deeply humbled and, quite challenged and moved by the energy, the passion, the stallholders, and the various discussions we've had today. So this is a reminder of what we can do when we come together, and it's great to see many known faces in the room. We want to do a couple of things, and I think we want to say thanks to our compares, Melissa and Nick. Can we put our hands together for them? Also, all the delegates, yourselves, the speakers, the contributors, the lived experience in the workshops, we're going to write them up and share with you. So massive thanks for all that. And then also to our sponsors, we want to recognize you because we couldn't have done this. You know, I remember saying to the co-chairs on, one of our planning meetings that we want to move here because last year we felt a bit, cramped. And we didn't know how it was going to happen, but with our sponsors, we couldn't. So can we put our hands together? We have little tokens that are, so co-chairs, could you go into the middle a bit so that I'll call reps from our, sponsors to receive little tokens. So the first, help me. So AstraZeneca. Whilst AstraZeneca. So Rosie, the National Lottery Community Fund, David. Gilead, Rebecca colleagues, someone from Gilead. Right, we'll hand that over to them later. Impact on urban health, Sham, I can see you at the back. Katie from Social Finance.
Thank you so much for your support. Really appreciate it. From us to you.
Thank you so much.
And I think the final one is Vertex. Is anyone from Vertex? If not, we will hand over. But we can put our hands together for them in a second. So your partnership means a lot, and hopefully next year we will have you all. The final thing, behind the scenes, so if you don't follow Inspire on social media yet, you can see how yesterday, a couple of us were putting things together. Our team has worked really hard, and I think it will be good to put our hands together for the delivery team. The other unique thing about Inspire is that it wouldn't be possible without our co-chairs as well as our steering group members. So if there are steering group members in here, this morning some of you saw them, hands-on doing stuff. So can you stand up so we appreciate you? Steering group members from Inspire. Or you can see them over there. Many thanks to you all for giving your time, and I know many of them are not here. And I think the final bit is to recognize our co-chairs. They're not removed, they're hands-on. They really want to make... No, we absolutely love you to bits. So, we've got some flowers. I want to say massive thanks for your leadership, without which Inspire wouldn't be where it is. And so finally, we have drinks reception on the 5th floor. There'll be a violinist performing and lots of networking could happen. But as we leave today, let's carry the momentum that was built in here. The pledges, the Mentimeter will remain open, but the connections we've forged and the ideas that have been shared, we want to make sure that makes a real difference. So please keep in touch. You can follow, Inspire on social media. If you want to be involved in any of the task and finish groups, then please let us know, as well as the Caribbean African Health Network, which I have the incredible privilege of leading. And so the final bit is, if there are CAN staff here, can you be upstanding so that we do final applause before I hand over to Nick and Melissa? CAN. But we also have our amazing chair. Oh, well, I think they're all downstairs. And also massive thanks to our chair for all your support behind the scenes and what you do. So finally, can I invite and hand you over for closing words from our amazing co-chairs. And if you don't follow them on social media, please do, because we've got to celebrate our own. Oh, please come up. But also Levi Roots, massive thanks from myself. We met just a few weeks ago. He said, I'm going to turn up. I'm going to support. So it's great to see you.
Well, on behalf of myself and Melissa, we'd like to thank the Caribbean and African Health Network, LDNinspire, and everyone who's helped make this possible. It's been an absolute honor and privilege to be part of this event for the second time in a row for myself, and to be able to listen to some amazing speakers, some wonderful thoughts and reflections on something that is so important to a lot of people in this room. I can see people who are nodding so much at some of the things that they were listening so intently at some of the things that we were hearing. Professor Bola Obalabi's moving speech about how important this is, Professor Habib Nakvi. I could go on and on and on, but honestly, I cannot thank the people behind this enough for everything that they've done. So, yes, thank you.
I also just want to say thank you. Thank you for being here and being so warm and kind. It's been lovely to connect with some of you outside of this room. And also thank you to Khan. Thank you to the co-chairs. Thank you to Charles. Charles looking sharp. We love that. And thank you to all of you. Thank you to every single one of you that came here today. And before we go, I'm going to try and do something. I don't know if it's going to work, but you guys really kind of have to help me out a little bit here, okay? I want to see if we can take a group selfie. We're going to do it. We're going to do it. So basically, I'm going to stand here, and I'll count down 1, 2, 3, and I want you all to shout, Inspire 2025. Yeah, you got this? I know it's the end of the day, but work with me, people. Come on. There's drinks after this, so you can liven up a bit. So, yeah.
Do you want me to stand here, or? Yeah, sure.
Oh, there we go. Lovely. So, 1, 2, 3. Inspire.